Good morning, everyone, and welcome to all the participants and the delegates from Australia and our national faculty. As you all know, we have been continuing doing a series of online medical education teaching programs, and this module is on thyroid. So this meeting is only possible because of the support which we get here in the form of the encouragement we get from Dr. Vishal Rao and the whole team here, our fellows, Dr. Joshna, Dr. Apurva, my colleagues, Dr. Shalini, and the whole of the team at HCG. So with this little introduction, I will just hand over the screen to Dr. Vishal Rao to give the introductory remarks, and then I shall be introducing the moderator for the day. Over to you, Vishal, sir.
Thank you, Akshay. So at the outset, I would like to thank all the institutions participating in this program. I have specially to thank Chris O'Brien, Lifehouse, the Global Health Academy, the HCG Academics. I have Dr. Ravi Nair also joined in here, who's our Dean of Academics. And the whole idea that we started with this about 6 months back was when Akshay was discussing about how we could keep ourselves productive, and that's how during this corona times we had a lot of time in our hand, and we thought we could structure some amount of academic programs, and we came out with this continued online medical series in which he presented laser followed by that oral cancer. So now we are troubling you all with thyroid. So the whole idea here to all the participants was that we will archive all these videos, so this can become ready reckoner for each one of you in these various topics to go through in any of your academic programs. We'll keep these resources open so that each one of you all can use it for any of your teaching programs, for your residents, fellows, to keep it for ready references in the future. I would also like to welcome all the participating organizations. I can see from across India, Amrita, we can see from other institutions such as Aster, Apollo, and several other hospitals, people who have joined in. Tata Hospital team, Dr. Devendra sir has come in. I would welcome all of the senior members here for sparing your valuable time for this program and participating with us. And we hope this particular sessions will be fruitful. We tend to keep the topics meaningful, but if you have any more suggestions or any other comments, please do tell us so that we can improvise it for further sessions. And we've also been thoughtful of the fact that today there are too many webinars and it's kind of setting into a webophobia. So how can we even prevent this kind of a thing, but yet keep content meaningful and keep ourselves interactive and productive during this COVID times is something we've been trying to achieve from HCG Academics, and we'll continue to pursue this. So your comments and suggestions will be very welcome. I again thank all the participating organizations who have spared their valuable time to encourage us, support us, and guide us in this. And I think I'll, without much ado, especially would also like to welcome Dr. Dr. Carlston Palm and Dr. Luke from the University of Australia to have joined in from the international team, and let the sessions of this program take over from here on. Again, thank you all for sparing this valuable time on a Sunday morning to come forward and participate in this program. Akshay, I think we can start the programs.
Right. So I would now request Dr. Mahamaya to kindly take over the session for the day. Mahamaya is a good friend of ours. He is a head and neck surgeon, done his training from Afirma Institute of Medical Science, Kochi, and currently he is working as a head and neck surgeon at Guwahati, Assam. Over to Mahamaya to moderate the session for the day. Over to you, Maya.
Thank you, Dr. Akshay. I'll now just share my screen. Good morning to all the speakers and participants, and good afternoon to our students from Sydney, Australia. Welcome to the continued online medical education series, Head and Neck Thyroid. Today in the morning session, we have eminent guest faculties from across the world who will share their knowledge and experience to us. Before I introduce to our speakers, we have 5 talks. Each talks will be of 20 minutes duration, including the question answer round. So our first speaker is Dr. Sashikant Limbachia. He is currently working as a consultant head and neck cancer and reconstructive microvascular surgeon at the Narayana Multi-Speciality Hospital, Ahmedabad, Gujarat. He will be followed by Dr. Peter Luke. He is a staff specialist at Royal Prince Alfred Hospital and a senior lecturer at the University of Notre Dame. His main interest is in head and neck pathology and works closely with the Sydney Head and Neck Cancer Institute at Chris O'Brien Lifehouse. Next speaker, Dr. Michael Elliott. Because of some unavoidable circumstances, he will join us in the next Sunday for his talk. Next speaker will be Dr. Carsten Palm. He is the Director, Department of Head and Neck Surgery, Chris O'Brien Lifehouse Cancer Center, and Clinical Associate Professor in the University of Sydney. He holds clinical appointments at Royal Prince Alfred Hospital and Westmead Hospital in Sydney as well. Next speaker will be Dr. Anil Diku, sir. He has over 30 years of experience in the field of surgical oncology, focusing primarily on head and neck cancers. He is the current director at Oncology Apollo Hospitals. He was also the ex-director at Tata Memorial Hospital, Mumbai, India. He is a researcher, administrator, and a crusader in the field of cancer control, and he now holds the president post of UICC for the term 2020 to 2022. Thank you. With this, I'll hand over the podium to Dr. Shashi for he will be speaking on surgeon's approach to thyroid gland, historical vignettes, and anatomical perspectives. Thank you. Shashi? Yeah, Dr. Shashi, yeah, you can share your screen.
Is it visible?
Yes, Shashi, it's visible.
It's visible. Go ahead.
Thank you, Dr. Mahamaya, for introduction. Thank you, HCG team, for giving me this opportunity and conducting this nice workshop. The history of thyroid surgery is amazing and very interesting. It has many twists in the road. The first mention of goiter in China occurs as early as 2700 BC. In 8500, there was recorded to be the first goiter excision, though the patient survived despite of massive postoperative bleeding. Between 12th to 16th century, there were few unsuccessful attempts were made. If you see the first picture of School of Salerno, Italy, the surgeon is inserting 2 heated iron acetons in the neck of a mass. The assistant is holding the patient in a chair. The first illustration of thyroid was given by Leonardo da Vinci. The first term to the thyroid gland, the glandula thyroidus, was given by Thomas Watt. The first thyroidectomy was performed in 1646 on a 10-year-old girl, and unfortunately the girl died and the surgeon was imprisoned. Till 19th century, so many efforts were made. The collar incision was introduced by Jules in 1880s. The surgical revolution came in 19th century. Till date, the mortality rate was almost 40%. The landmark development in surgery occurred in 19th century and converted this bloody and condemned procedure to the modern and safe surgical intervention. The 3 major steps of this revolution are invention of anesthesia, antisepsis, and surgical hemostasis instrumentation. These are the 2 giants who developed the modern thyroid surgery, Dr. Albert Billroth and Professor Kocher. The Professor Kocher, he acquired the skills so fast and performed more than 5,000 thyroidectomies. He introduced the initial ligation of inferior thyroid arteries, which substantially reduced the risk of hemorrhage. During his time, the mortality rate came down from 12 to 12% to less than 0.2. He also has given the role of thyroid, the physiology of thyroid in growth and development. He was awarded as a Nobel Prize for his work in physiology, pathology, and surgery of the thyroid. And he has been acclaimed the father of modern thyroid surgery. You can see the picture on the left, the girl, who, a 10-year girl, who Kocher has operated with his younger sister. But at the age of 20, she has having a stunted growth, and her younger sister looks bigger than her. After that, so many big surgeons gave their contribution to the modern thyroid surgery. The role of the laryngeal nerve was, in reference to the voice, was reported early in 600 BC by Sushrut Samhita in India. Galen was the first who described the recurrent laryngeal nerve in detail. You can see in this picture, Galen is describing the role of recurrent laryngeal nerve in a live pig, operating on a live pig to his elders. At that time, the common practice for preserving the nerve was to identify the inferior thyroid artery, isolate it, and ligate it laterally away from the nerve in a bloodless field. So many surgeons recommended leaving the posterior capsule or the remnant of thyroid to preserve the nerve. Coming over to the debate of visualization of the nerve, whether to dissect the nerve and visualize it while thyroidectomy. Riolu wrote in 1933 that if nerve is seen, is injured. And the philosophy of purposely not seeing the nerve, which influenced the entire generation of surgeons and still exists in the mindset of few surgeons till date today also. But if we see the data by Zetso, if we are identifying the nerve, the chances of injury to the nerve are less. The little attention was paid to the superior laryngeal nerve until 1935, when world famous operatic soprano Emelita Gulli, when she underwent a goiter surgery, she lost her upper vocal registry and the SLN came into the limelight. Now coming on to the embryology part, the thyroid arises from a double origin, primitive pharynx, endoderm of the primitive pharynx, and the neural crest. The primitive pharynx form the major bulk of the thyroid gland, and neural crest along with ultimobronchial bodies form the parafollicular and C cells. The thyroid reaches its normal position by the 7th week. The superior parathyroid arises from the 4th pharyngeal pouch and inferior by the 3rd pharyngeal pouch. The thyroid lies in the front of the neck, anterior to the trachea. It has 2 lobes connected by the isthmus, which lies at 2nd to 4th tracheal ring. The average size is around 5 into 3 into 2 centimeters for each lobe, and it weighs around 20 to 30 grams. We all know the relation of the thyroid along with the neck structures. Thyroid is having a peripheral condensation of fibrous stroma, which forms the true capsule around it, and the dense venous plexus just lies deep to this true capsule. There would be a false capsule which formed by the pretracheal deep cervical fascia, that is also called as surgical fascia, and in between this is a plane of cleavage for the surgeons. The pretracheal layer forms a thick condensation near the thyroid attachment to the laryngotracheal complex, and it forms the suspensory ligament of the baby. So sometimes the RNL nerve passes through this ligament, and care must be taken as one of the branch of inferior thyroid artery also supplies this. There are 2 paired superior thyroid arteries and 2 paired inferior thyroid arteries, which supplies the thyroid. Inferior thyroid artery also supplies the parathyroid. In 3 to 10% of cases, there might be a thyroid ema artery, which is unpaired, which usually arises from brachiocephalic trunk, but occasionally it can arise from aorta directly, or right common carotid artery, or the subclavian, or the internal thoracic artery. So care must be taken to identify this artery while performing thyroidectomy or tracheostomy. There are two pairs of superior thyroid veins, middle thyroid veins, which drains into the IGV, while the inferior thyroid veins, which drains into the brachiocephalic vein. So most of the thyroid is drained by inferior thyroid veins. Now coming to the surgical anatomy of superior laryngeal nerve, which originates from the inferior ganglion of the vagus nerve, just 2 centimeters below the jugular foramen. It descends posterior-medially to the internal carotid artery, and at the level of greater cornu of the thyroid cartilage, it gives two branches. One is the internal branch, which supplies the supraglottic and pharyngeal mucosa, and one is the external motor branch, which supplies the cricothyroid muscle. The identification of external branch of superior laryngeal nerve is very crucial while performing the thyroidectomy. So as we have seen in the history, it affects the high pitch volume. So mostly it affects the woman or professional singers. There are multiple classification systems has been proposed. So one of the most widely accepted classification system was given by Cernia. He has given 3 classification systems, type 1, type 2A, and type 2B. You can see in this figure, the most common is type 1. In their series, they have found it around 60 to 68% of the nerve above 1 centimeter of the plane of the superior pole crossing the superior thyroid pedicle. There are other classification systems given by Kerners and Friedman also. The identification of this nerve can be easily done if we dissect the avascular space of reeds, and this maneuver helps in diagnosis of the external branch of the superior laryngeal. Now coming to the surgical anatomy of recurrent laryngeal nerve, it arises from the 6th branchial arch, and the course of this nerve is determined by the pattern of the development of the arteries related. So if the recurrent laryngeal nerve develops without any alteration, it will originate from the vagus nerve, and on the right side, it curves around right subclavian artery, and on the left side, it surrounds the aortic arch. So here you can see in this picture, the left recurrent laryngeal nerve, which arch around the aortic arch and ascends in the brachioesophageal groove. Its ascent is almost straight in the paratracheal position. The approximate length of left recurrent is around 10 centimeter. On the right side, the right recurrent laryngeal nerve, it arises near the division of the innominate artery and loops around the subclavian artery, and it approaches the tracheoesophageal groove little obliquely. The approximate length of this nerve is around 7 to 8 centimeters. This nerve enters the larynx deep to the inferior constrictor muscle and posterior to the cricothyroid joint. And within the larynx, it divides into 2 branches. One is the anterior motor branch and one is posterior sensory branch. Sometimes the anastomosis between the superior laryngeal nerve and recurrent laryngeal nerves are also present. It's called as Gallen's anastomosis. There are multiple variations also present, and it has been described in the literature. So one should be very aware about these variations, and extralaryngeal branching of the recurrent laryngeal nerve also would be present. Don't mistaken the inferior thyroid artery with the branches or true recurrent laryngeal nerve. The artery would be in around 2 to 3 millimeter in diameter, but if you see the nerve, it would be round in shape and whitish just beneath the translation fascia. There would be red vascular strip of vasa nervosa, and you can identify the nerve, discriminate the nerve with the artery. These are the landmarks to identify the recurrent laryngeal nerve. We will see each in detail. The first is the tracheoesophageal groove. So in 70 to 75% of cases, on the left side, the left recurrent laryngeal nerve can be found in the tracheoesophageal groove. And on the right side, in around 60% of the cases, it can be found in the brachioesophageal groove. The relation of the recurrent with inferior thyroid artery on the left side, in around 50 to 55% of cases, it is posterior to the inferior thyroid artery, and in 33%, it would be between the distal arterial branches of the inferior thyroid artery. While on the right side, in majority of cases, it would be between the distal arterial branches. The next landmark is Barry's ligament. As we have seen, it is a thick condensation of the fascia capsule around the thyroid with a laryngotracheal complex, and in most of the time, the nerve enters posterolateral to the Barry's ligament, but there are multiple variations also present. Zucker-Kendall's tubercle is a thickening of the thyroid gland, which is at the posterolateral aspect. It had been thought to be the junction of medial analog and lateral analog while the embryological fusion. It present in around 60 to 90% of adult gland, and in most of the cases, the nerve enters deep and medial to the tubercle. Cricothyroid joint, or if we can tell, it is a laryngeal entry point. The lower edge, if you can palpate the lower edge of the cricoid cartilage, this would be the consistent landmark while performing total thyroidectomy to identify the nerve. The nerve can be identified regardless of any substernal or large goiter. Even the non-recurrent nerve can also be identified if we do the meticulous dissection around this entry point. Now the approach is to identify the nerve. So most common approach is a lateral approach. If we open the virgin neck and retract the thyroid medially and straps laterally, the nerve can be identified at the mid-pole level. And the advantage of this is we have to limit the dissection near the nerve, and we can preserve the blood supply to the inferior parathyroid as well. The inferior approach, when there would be a revision case or large cervical goiter, this approach is also better. And the disadvantage of this approach is it can potentially devascularize the parathyroid gland. The nerve dissection would be little larger. Superior approach to identify the nerve at the entry point. So this would be helpful when there would be a large substernal goiter, or to identify the non-recurrent branch also. This approach is best because of the constant anatomical position of this landmark. But one has to be very meticulous because there would be tough attachment of Barry's ligament here. It is well vascularized. There would be 1 or 2 branches of inferior thyroid artery which supplies this area, and there might be extra laryngeal branching of the recurrent laryngeal nerve. Non-recurrent laryngeal nerve is very rare. It would be 0.6% on the right side and less than 0.02% on the left side. It would be associated with a vascular anomaly, like when there would be aberrant takeoff of right subclavian from the descending aorta or right side aortic arch. It may take off as high as superior pedicle or as low as inferior thyroid artery. Parathyroid glands are 4 in number, and they would be less or more in 2 to 6% of cases. There would be supernumerary glands when they found distal to the normal parathyroid. How to identify the parathyroid from thyroid tissue or lymph node? We can identify it by its shape, color, or size. The parathyroid would be light brown or reddish tan in color based on their fat content. But in contrast to the fat, which is very yellowish, bright yellow in color, if we have to discriminate it from thyroid, thyroid would be having reddish mottling, and it would be little firmer than parathyroid. And lymph node also would be firmer than parathyroid. We can identify the parathyroid by gliding sign. As the parathyroid is having very loose capsule, there is no capsular fixation. It lies in the fat lobules, and the gland can be easily mobilized in that fat lobules. By the plane of recurrent laryngeal nerve in the coronal plane, we can identify the nerve, we can identify the superior para, which would be dorsal to this plane, and the inferior para, which would be ventral to the plane. These glands are having positional symmetry. So in 80% of cases, upper para would be symmetrical, and in 70% of cases, the inferior para would be symmetrical. The principal blood supply to these glands are from inferior thyroid artery in most of the cases, but it can be from the posterior branch of the superior para can be from the posterior branch of superior thyroid artery, or might be from the anastomotic vessels of these two. So where to identify the superior parathyroid? So in most of the cases, it would be within the 1 centimeter of area around the cricothyroid cartilage or joint, or we can say 1 centimeter cranial to the interaction between the inferior thyroid artery or recurrent laryngeal nerve crossing. So this is a table. I have taken it from the textbook of Professor Gregory Randolph, and inferior para in 50% of cases, it can be identified within the 1 centimeter radius from the inferior pole, either inferiorly, laterally, or posteriorly. In 25% of cases, it can be identified near the thyrothymic horn. So meticulous dissection just beneath, it will be very superficial. Meticulous dissection just beneath the strap in that fibrofatty plane, we can identify the inferior para. The lymphatic drainage of the thyroid is profuse and multidirectional. That would be cross communication also through the isthmus and each lobe. So it is difficult to predict the thyroid lymphatic drainage. But in most of the cases, the primary echelon nodes, which are the Delphian prelaryngeal nodes, pretracheal nodes, or paratracheal nodes, which bounded by both side carotid, hyoid, and suprasternal notch. And the secondary drainage would be to the upper, middle, and lower jugular chains, but in superior pole can directly drains into the upper jugular chains. Thank you so much.
Thank you, Dr. Sashi. Now we will take up questions if we have.
Shashi, can I make a point here?
Yes, sir.
Yes, sir.
A lot of the times when there is lymphatic metastasis from thyroid, there is a lot of retrojugular lymph nodes, especially if the tumor is in the inferior pole. So normally when we dissect the lymph nodes in a neck dissection, it's between the sternocleidomastoid, the prevertebral fascia, and the carotid sheath. But if you have a lower pole thyroid malignancy, there is a lot of chance that there is a high chance that the retrojugular nodes are involved, which means you have to work below the jugular vein. And that's where the node is commonly missed. So I think when you do a level 4 neck dissection for lateral compartment disease, we have to focus on the area behind the jugular vein and in front of the phrenic nerve, because a lot of these nodes are not in that area. But otherwise, your presentation was excellent, and it was really nice to see a lot of historical points being put across and things like that. So very well done presentation.
Thank you, sir.
Thank you, Dr. Sashi. There is one query from Dr. Yushu. She wants you to repeat the recurrent laryngeal nerve identification in surgical practice.
Can you repeat the question?
She wants you to repeat the recurrent laryngeal nerve identification in surgical practice.
Okay, so as I mentioned, there are 3 approaches. So if we have to do revision surgery, we can take superior approach or either inferior approach to identify the nerve.
Okay, thank you. One more question, Sashi. You have mentioned about the non-recurrent laryngeal nerve. So is there any way to identify it pre-operatively? You can make out that this might have a non-recurrent laryngeal nerve.
So while doing the imaging, if we are taking CT scan for the large uh, goiter or large thyroid malignancy, if we can see any aberrant vessel takeoff in the CT, either right subclavian is rising from the aorta or there would be right aortic arch. So if it is present, then we can presume that there would be non-recurrent symptom.
Let me,
And during inter
if you have a retroesophageal subclavian vein on cross-sectional imaging, then you would think of a recurrent laryngeal nerve. And like Shashi said, if you start at the lateral compartment and move towards the thyroid fascia, if you see any large nerve taking off from the vagus, do not divide, do not cut it until you have identified the recurrent nerve in the tracheoesophageal groove. So you've got to just remember that. Thank you.
Okay. Thank you, sir. So we will now move to our second talk, which is by Dr. Peter Luke. He will be talking on, can current molecular tests help in the diagnosing of indeterminate thyroid nodule in fine needle aspiration biopsy? Dr. Peter Luke, to you, sir.
Thank you for the introduction, and thank you for the opportunity to give this talk. So at the start of the talk, I'd like to just touch upon what we mean by indeterminate nodules for pathologists. So as you know, in thyroid FNAs, pathologists use the Bethesda system to categorize the pathology. So in one spectrum, we have benign, in which Bethesda 2, in which we have plenty of colloid and we see follicular cells which are bland and usually in sort of macrofollicular pattern. And on the other hand, we have malignant nodules, Bethesda 6, which we are confident that they're malignant because we can see nuclear features of papillary thyroid carcinoma, such as nuclear grooves and pseudo-inclusions, or we can see anaplastic pleomorphic looking malignant cells. Now, the issue is the stuff in between. So, So Bethesda 3 is atypia of undetermined significance, in which is when the pathologist is not sure whether this is a non-neoplastic or a neoplastic follicular process. And this accounts for about sort of 15 to 30% of thyroid FNAs and carries a risk of malignancy of 10 to 30%. And the usual management historically is to repeat the biopsy after an interval, which depends on the clinical and radiological suspicion. But what do pathologists mean by atypia? Well, it is actually an umbrella term for a number of things that we can see. One is cytological atypia, in which we could see focal nuclear features, focal nuclear changes, or extensive but mild nuclear changes, or atypical cyst lining cells. And then we can have architectural atypia, which often means a sparsely cellular sample, but one that is predominantly microfollicles, though, so we sort of worry about a neoplastic process. And then we can have a combination of both cytologic and architectural atypia. And finally, if we see a predominance of HER2 cells, we worry about whether this is a HER2 cell neoplasm. And we categorize into 3 if it's not cellular enough to call it an actual neoplasm outright. So some examples of what we call Bethesda 3 is, for example, in this case, which is a cellular smear, but there's no colloid at the background, and there's a few microfollicles hanging around. So we're not sure if this is a hyperplastic or neoplastic lesion. And in another case, this is a very paucicellular smear in which we don't really see any cells at all. But if we do find one group of cell which has some nuclear atypia, in which there's nuclear overlapping and perhaps a hint of a nuclear groove, then we worry whether this might be a cystic papillary carcinoma, but just very sort of cystic and not having sampled the cells. Then we also call it a 3. So Bethesda 3 really is a wastebasket for pathologists that we put it into when we're not sure what it is, but it can encompass a whole range of morphology. So Bethesda 4 is when we have follicular neoplasm, and then it includes both follicular and hydrocell adenomas and carcinomas. And the reason being that the only way to tell the difference between adenoma and a carcinoma is by histological examination of the capsule for capsular or vascular invasion. And this is an example of follicular carcinoma. It's a histological section. In the bottom, we see the lesion with the sort of closely packed nests and microfollicles. And here we have the fibrous capsule, and the lesion is penetrating through the capsule into the thyroparenchyma. But if you imagine sticking a needle through that, we'll only be able to see the cells, and we will not be able to see this sort of capsular or transcapsular growth. So on cytology, it's impossible for us to call something follicular carcinoma. So in recent years, molecular testing has been increasingly used to improve the performance of FNAs. So in the most recent American Thyroid Association guidelines, 2015, they have suggested that molecular testing may be used to supplement malignancy risk assessment in FNAs. And in particular, they suggested that a molecular panel, including markers such as BRAF, RAS, RAT-PDC, and PAX-A PPAR gamma can significantly improve the accuracy of FNAs, but they did not endorse any specific molecular test or a specific panel. So then the new paradigm is to, if you have an indeterminate FNA, then you can do molecular testing, which can then help you determine whether to recommend surgery or recommend continued observation. So at this point, I just want to say that in Australia, we do not routinely perform molecular testing on FNAs. So the data that I'm presenting here is from a literature review of the sort of commercially available molecular tests in America. And there are currently 3 commercially available platforms. One is the Thyroseq, next one is the Afirma platform, and then the last one is the ThyGenNEXT and ThyraMIR platform, and which I will discuss each of them in turn. So Thyroseq is a panel that, or a test that sort of started back in 2007. And it initially started as a 7-gene panel that included BRAF, the RASes, RAT-PDC, and the PAX-A PAR gamma translocations. And then subsequently, with the introduction of next-gen sequencing, further versions of the Thyroseq panel came out. So in 2013, the 15-gene panel came out, then the 56-gene panel, and then the most recent version, which is the currently available in the market, is the Thyroseq version 3, and it interrogates the selected regions of 112 thyroid cancer-related genes for point mutations, insertion deletions, gene fusions, as well as copy number alterations, and it includes more than 12,000 mutation hotspots in the platform. So the Sentinel paper, or Sentinel study, which looked at this Thyroseq version 3, is by Stewart and colleagues, which is prospective blinded study conducted in 10 sort of multi-center study, looking at 247 indeterminate nodules. So if we have a look at the results, which is broken down to Bethesda 3 and 4 nodules, if we look at the molecularly positive group in the Bethesda 3 category, so 32 cases were cancer or NIFP, but there were also 18 cases in this molecularly positive group that were benign. But on the other hand, in the molecularly negative group, only 3 cases were malignant or NIFB, and the vast majority were benign. And the same pattern can be seen for Bethesda 4 nodules. So when you group the 3 and 4 nodules together, the overall sensitivity of this test is 94%, and the specificity is slightly lower at 82%. So that gives you the negative predictive value of 97 and positive predictive value of 66. And you know, for me, all these numbers and sensitivity and specificity is always really confusing. What does it actually mean? Well, in simple terms, this test has high sensitivity. So if you have a negative test, then you can be fairly confident that you can rule out a cancer, that it is a benign nodule. So it's a good test for ruling out malignancy. But if you have a positive test, then it's not as helpful, because whilst, you know, a lot of these do turn out to be malignant, there is a significant proportion of these cases that are benign. So if we look at the breakdown of the mutations that were detected in this study, there are certain mutations that are strongly associated with malignancy. So things like TERT, promoter mutations, P53, BRAF, of course, and then there are NTRK and RET fusions that are also strongly associated with malignancy. But then there are mutations in sort of other genes, such as the RAS-like group, including the various RASes, which are sort of, you know, less predictive of malignancy, as, you know, almost 40% of these are actually present in benign lesions. And the same goes for the copy number alterations. So around 40% of these are also were, you know, found present in benign lesions. Although in the malignant lesions, a lot of them do turn out to be HER2 cell carcinomas. So we look at the Afirma platform. So this initially was called the Gene Expression Classifier, or GEC. So this was this platform uses a next-gen sequencing of RNA expression in 167 genes, and uses, you know, a very complex machine-derived algorithms that looks at the mRNA expression to determine whether the nodule is benign or suspicious for malignancy and from a molecular point of view. So the study that looked at this was done by Alexander and colleagues, which was a prospective multi-center study, and included 265 indeterminate nodules. And if we just look at the combined Bethesda 3 and 4 data set, which is the one up here, the cases that were molecularly suspicious, 78 cases turned out to be cancer, but then there were also 87 cases that actually were benign. But in the molecularly benign group, only 7 were, turned out to be malignant. The vast majority were benign. And the same pattern can be seen whether you look at it so separately as Bethesda 3 or Bethesda 4. So this platform gave us an overall sensitivity of 92%, but a fairly low specificity of only 52%. And then, so they try to improve upon this platform, which is now the currently sort of the one available on the market. And this is the Genomic Sequencing Classifier, or the GSC. And this incorporates nuclear and mitochondrial RNA gene expression, as well as the RNA sequencing and genomic copy number analysis. And so, and this platform now includes more than 10,000 genes in its algorithm. And the study looking at this platform was done by Patel and colleagues in a prospective multi-center study looking at 190 indeterminate cases. And if we look at the combined data set for Bethesda 3 and 4, we can see that the molecular suspicious cases, there were 41 that turned out to be cancer. There were also 46 cases that turned out to be benign. And in the molecularly benign group, only 4 were malignant. Vast majority, again, turned out to be benign. And the same pattern, again, seen in Bethesda 3 and 4, if you consider them separately. So in this platform, you have an overall sensitivity of 91%, but again, specificity is not as good, only at 68%. So with the last platform, ThyGenNEXT and ThyraMIR, it's actually a multi-platform test that consists of two tests. The ThyGenNEXT, it detects the mRNA fusion transcripts as well as DNA mutation in 20 specific genes that include BRAF, RAS, PIK3, CA, PTEN, and TRET promoters. And while the ThyraMIR uses a quantitative RT-PCR to detect the expression of 10 specific microRNAs. So the algorithm of this test is that you start with ThyGenNEXT. If you detect a strong mutation such as the BRAF and TERT or RET-PTC, then the test is regarded as positive and the surgery is recommended. But if there are no detection, if no mutation detected, or if there is a mutation in the sort of a weaker gene like a RAS, then they move on to the ThyraMIR test, which then further classifies this lesion. So the study looking at this platform was done by Lupo and colleagues in a multi-center retrospective study in 197 cases. And in this study, they looked at a sort of a three-tier system rather than two-tier system. And if we look at a combined Bethesda 3 and 4 nodules, in the molecularly negative group, the vast majority turned out to be benign, only 4 malignant cases, whereas the molecularly positive group, there's a sort of fairly high proportion of them being malignant, but a small proportion of them do turn out to be benign. But then they do have this moderate group in which it's kind of indeterminate molecularly, where you have quite a few benign, but some malignant cases as well. And same pattern again seen in both Bethesda 3 and 4 nodules separately. So in this particular test, if you, for the authors, they regarded negative, so the calculation of sensitivity and specificity is based on negative and the positive criteria only. If you consider those two criteria, then the sensitivity is 93%. And the specificity is 90% if you only look at the positive molecular cases. So then sort of in summary with these, if we compare these three tests side by side, we can see that the sensitivity among them is fairly similar, of above 90%, and negative predictive value or over sort of 96%. But the specificity is variable, and it's consistently lower than the sensitivity of these tests. The ThyGenNEXT and ThyraMIR one quoted specificity 90%, but then it doesn't seem to take into account that sort of a moderate risk group, which is fairly indeterminate. So I think in conclusion that the molecular tests are helpful in a way in sort of further stratifying these indeterminate FNAs, in the sense that they are sensitive, but they are less specific. So if you have a negative test, then it's very useful to exclude malignancy and avoiding unnecessary surgery. But if you have a positive test, then that is less helpful because, obviously, a large proportion of these do turn out to be malignant, but then, quite a few of them do turn out to be benign as well. And no test has 100% sensitivity. So as I said, in Bethesda 3 group of lesions that encompasses a whole lot of different morphology. So I think a lot of this has to do with sampling issue, that if you're not sampling the lesion properly, say if you're just sampling the cystic contents, then no molecular test is going to be accurate. So I think at the end of the day, the decision regarding surgery versus observation really is based on a combination of cytologic, molecular, clinical, and radiological findings, as well as patient preference. Thank you very much.
Thank you, Dr. Peter Luke. If you have any questions, I'll forward it to Dr. Luke. Yeah, it seems there are no questions from our participants. So just I'll ask one thing, sir.
Sure.
This positive result, this only predict malignancy. So it does not always indicate that it's an aggressive malignancy where we have to change our treatment protocol.
Yes. So I think a positive result does not carry a huge amount of weight. I think it's I think there are certain mutations such as like TERT mutation, TERT promoter mutation, BRAF, RAT-PTC, which these are strongly associated with malignancy and aggressive disease, whereas these ones are perhaps more reliable. But I think the vast majority of the sort of the panels and the sort of gene expression and all that stuff, when they do spit out something positive, it does not necessarily mean malignancy, and really the decision then will have to rest on the clinical and the radiological and the other factors.
Okay, thank you, sir. One more question to you. This is from Dr. Abhishek B. Singh. He wants to know which is best to rule out and which is best to rule in.
I don't think there is a specific test that is best as such from the evidence in the literature. I think all of the panels perform in a fairly similar, have similar performance, and all of them are very good at ruling out malignancy. But I don't think any of them are, able to reliably rule in a malignancy at this point.
Okay, thank you, sir. So thank you so much for your nice presentation. There is one question. Okay, thank you, sir. So we will now move on to our next talk, which was by Dr. Michael Elliott. However, he's not available today. So we will move on to our fourth talk, that is by Dr. Carsten Palm. He will be speaking on extent of thyroidectomy, utility of guidelines and scoring systems in preoperative prediction of thyroidectomy. Sir, over to you, sir.
Can everybody see my screen?
Yes, sir.
Great. Dear Dr. Singh, thank you very much for this honor. And to my colleague and good friend, Akshay Gudbachi, and also Dr. Vishal Rao, thank you very much. I think this is such a wonderful initiative, and you really should be congratulated for this amazing amount of work you've done in putting in all these webinars. I've been charged with the topic today of talking on the extent of surgery in well-differentiated thyroid cancer, and I really would like at the outset to let everybody know that this is a personal perspective. Treatment of thyroid cancer is actually can be quite controversial on many aspects. And what I'm going to present today is by no means comprehensive, and it's very much a personal opinion. Now, let me... So thyroid cancer, just to go back to the epidemiology, we've really seen a massive increase in number of cases. Certainly in Australia, we've seen a doubling or tripling of cases. But fortunately, the death rate hasn't changed. And really the question beggars, why is this happening? Are we picking up all these incidental micropapillary carcinomas that we shouldn't really be picking up? And when we look at the epidemiology, probably about 10 to 30% of the world's population has a little bit of cancer in their thyroid. And given the increased use of high resolution ultrasounds, we're certainly picking up a lot of these cancers. But fortunately, the death rate, and certainly here you can see the CS database hasn't really changed. And these results have certainly been mirrored in our units in Australia. I mean, how do these patients present? And as I said, the vast majority of patients with well-differentiated thyroid cancer are essentially asymptomatic. Somebody notices a little lump in the neck, a relative or a doctor, or an ultrasound is performed for some throat discomfort or Globus type of symptoms. And the feared invasion of the upper air digestive tract although in some units approaching about 20%, which I think is mainly due to those high volume centers with specialty, is actually pretty uncommon. Neck disease, in terms of lymph node presentation, can occur in up to a third to a fifth of patients, but again, generally it's pretty uncommon. However, what is common is micrometastatic disease. And we know from these wonderful studies done by the Japanese that all levels covering 2, 3, 4, and 5, including 6, have very high rates of micrometastatic disease. So if you look at the central compartment, you know, that rate is well above 50%. But we must not forget level 4 and level 3, where the incidence approaches 40 to 50%. And certainly that really drives the way we do neck dissection, where we're encompassing those levels in patients that present with clinically relevant disease. Distant disease does happen and is possibly present in 5% of people, up to 5%. But again, I think that's probably a bit of an overestimation in terms of what we see in clinical reality. Oops. When you look at the staging system, there has been a significant change. And really one of the biggest changes that has occurred is that the age cutoff, where before it was 45 years of age, has been lifted to 55. Minor extrathyroidal extension has really been eliminated as a factor that upstages patients. And certainly even gross extrathyroidal extension, although initially be seen to be a stage 4 or T4 category, has now been downgraded. And if you look at the staging, if you're less than 55 years old and a woman, you can only really become a stage 2 if you have distant metastatic disease. And if you look at greater than stage 5, you really need to have significant extrathyroidal spread invading anything else other than the strap muscles to be upstaged to T3 or T4. What are the treatment options for well-differentiated thyroid cancer? Well, they are observation or active surveillance. One can perform surgery. Radioactive iodine certainly is used in an adjuvant setting, and thyroxine suppression is liberally used. External beam radiation is used in those people with residual macroscopic disease or patients who are inoperable for other reasons. And then there are certainly a number of trial drugs that have been looked at. The aims of treatment, intuitively, it's really to improve survival. But, you know, in patients who are younger than 55, that's a pretty difficult ask because a lot of those patients do extremely well. So I think improving survival is probably reserved for those patients with cancer who are older than 55. And one of the more significant things is actually to improve the disease-free interval and reduce the related morbidity. Treatment allows us, or surgery allows us, to accurately stage patients and allocate risk stratification. And importantly, one of the big aims is really to reduce treatment-related morbidity and avoid over-treatment, and importantly, avoid and prevent unnecessary, ineffective, and expensive therapies. When we look at the extent of surgery, we need to consider the thyroid clearly. We need to consider the neck lymph nodes and the upper air digestive tract. Clearly, surgery can be used at distant site, but this is a little bit beyond the talk today. So what do the decisions upon what we do rest on? Well, foremost, they relate to patient factors. And importantly, are we dealing with low-risk young patients? Are we dealing with high-risk male patients with a history of ionizing radiation and a significant family history? Are we dealing with patients who are cooperative and who are going to return for follow-up? It rests on tumor factors. Clearly depends on the type of pathology, the size of the tumor, what's going on in terms of the invasion, and what's the stage of disease. Is there a need for adjuvant radiation? And what is the possibility of surveilling these people? And importantly, physician factors really depend on the philosophy, not only of the surgeon, but also the endocrinologist and the institution upon which the patient is being treated. It certainly rests on volume of treatment, and we certainly know from other disease groups that the more you treat something, the better you're going to become and getting better outcomes. Memorial Sloan Kettering some years ago divided patients into low, intermediate, and high risk groups. And I think that's been actually a very beneficial and very valuable way of looking at patients. And again, a low risk patient would be a young female, less than 55, with a small tumor and no risk factors. And a high risk patient would be one male, older, with a larger tumor. And certainly, depending on where those patients fit, you are either going to upscale or downscale treatment. Importantly, Mike Tuttle has really taught us that in terms of factors, there are actually static factors, factors that we know that we can't change, such as patient factors, the tumor factors. But then there are also dynamic factors. Certainly, how does a patient respond to initial treatment that drives how aggressive we may be? And then importantly, there are a whole host of factors which we know is going to increase the risk of structural disease recurrence, which again will divide those patients into low, intermediate, and high risk patients. But overall, the decision depends on a risk-benefit analysis that will always need to be made in the, with the benefit to the patient. You know, we need to really balance, do we need to do a total thyroidectomy, central neck dissection, radioactive iodine for a 5mm incidental micropapillary carcinoma? And the answer is clearly no. So the decision always needs to be done with the patient clearly front and center. When you look at the evidence, and this is a great slide that kindly was given to me by Ashok Shaha, you know, the literature is replete with evidence on pretty well every approach for thyroid cancer. And the numbers of papers that are being published are staggering. So it is a very difficult field to get your head around. But one of the things that has really helped us has been a consensus of experts, which has really led to the American Thyroid Association guidelines of 2015. And importantly, personal opinion and experience goes into deciding how these patients are ultimately treated. I think it's much easier to start where there isn't any great dilemma, and that is those tumors that are greater than 4 centimeters, as you can see in that chart there. These are lesions that are clearly at high risk of recurrence and persistent disease. These are clearly lesions that are at high risk of extrathyroidal extension and significantly impairing disease-specific outcome. And in those patients, generally, the treatment, without doubt, would be a total thyroidectomy and aggressive removal of any lymph node disease and removal of extrathyroidal spread to facilitate a clear removal of the tumor, radioactive iodine, and certainly to improve surveillance with both ultrasound and thyroglobulin. Certainly in those tumors that are less than 4 centimeters that do show significant extrathyroidal spread or clinical neck or distant disease, again, I think there is little doubt and debate that total thyroidectomy would be the treatment of choice. When you get to tumors between 1 to 4 centimeters, this is really where the controversy starts. And this is where the risk stratification by Memorial into low, intermediate, and high has really helped us in deciding which patients are well treated with simple hemi or thyroidectomy or lobectomy, or those patients that need a total thyroidectomy up front. And when you look at some of the data, there is actually very little difference between a huge amount of people that have been treated with these low-risk tumors if you're looking between hemithyroidectomy and total thyroidectomy. Certainly the survival, there isn't any great difference. However, possibly those patients who've been treated with lobectomy up front probably have a higher rate of recurrence. However, they've all been able to be salvaged, which really has led to no significant difference in disease-specific survival. So again, ultimately, how you decide to treat this patient depends on the patient, importantly depends on the state of the other side when you're having a solitary nodule on one side, and importantly our institutional and physician philosophies. And really, the recommendations from the American Thyroid Association are pretty clear, that hemithyroidectomy in those patients with tumors less than 4 centimeters can be safely performed in those low to intermediate risk patients. I think a caveat is that you have a very compliant patient, a patient that understands the challenges and certainly agrees to follow up. Because as I said, the local regional recurrence rate is probably a little bit higher in those groups, however, has no effect on survival, and surgical salvage is possible. As we get smaller and smaller, the controversy increases. And here we are in those patients who, by definition, present with micropapillary carcinomas, on those cancers that are less than 1 centimeter in diameter. And as I said, if you look at autopsy studies around the world, the incidence is probably about 10 to 30% in the normal population. The treatments that have been offered to those patients has been anything from hemithyroidectomy, observation, to total thyroidectomy. And again, we need to consider patient factors, tumor factors, and institutional factors before working out what is the most appropriate patient for our patient who's sitting in front of us. If you're looking at those patients that have undergone surgery, and most of those patients would have undergone hemithyroidectomy potentially, they have very good outcomes. Mortality is low, local regional recurrence is low, and the development of distant metastatic disease is also very low. Active observation is a concept that really was started off by Professor Ito in a wonderful publication looking at patients undergoing a close observation. And he has clearly shown that tumor progression, and when you look at his original paper, that tumor progression was actually just a few millimeters, was actually pretty low, less than 5% at 5 years and less than 10% at 10 years. Unsurprisingly, in a way, younger patients were more likely to progress than older patients. And the question is, was that a factor of watching these people for a longer time, or are there some indigenous factors? Is a little unclear. Regional failure overall was also low at less than 5%. And really, there wasn't a whole lot of difference or issue in terms of survival. So when you look at what is the most appropriate way of treating these patients, as I said again, we need to put together all the factors as outlined, develop a risk-benefit analysis, and the options really are a period of active surveillance, surgery, and my initial recommendation would be to favor a conservative procedure. I don't really think there is a role for elective neck dissection, and base further treatment on what you found at surgery and those static and dynamic factors that Professor Tuttle has let us know. And I think you're going to do very well and treat your patients and avoid any unnecessary risks. What's the question in terms of completion thyroidectomy? And we might be in this situation if our initial plan was to perform total thyroidectomy, and we may have had a concern regarding the recurrent laryngeal nerve. So if you thought that at the initial operation that a total thyroidectomy was indicated, you probably should continue to do that. But if you initially felt that the patient might get away with a hemithyroidectomy, if you look at the factors there on the right-hand side, and if you have clinical lymph nodes, or if you have lymph nodes involved, it's a potentially multifocal tumor, and then there's an extrathyroidal spread or some other adverse features, there may be an indication, or and often is an indication, to complete and remove the other side. And certainly in those patients where you would feel that the addition of radioactive iodine and better surveillance with ultrasound and thyroglobulin would be beneficial, should all undergo completion thyroidectomy. If we're looking at neck nodes, and I'm really just going to summarize this fairly quickly, Clearly, if you have lateral neck nodes that are involved, you should perform surgery to remove those. However, if there are no clinical nodes, it is controversial. We do know from the series from Japan that micrometastases are incredibly common. However, the significance is significantly put in question. We do know that lymph nodes do have an impact on recurrence and survival, but probably only in older patients, male patients, those patients with large primaries, a significant amount of lymph nodes or greater numbers of lymph nodes, and certainly if there is any distant metastatic disease. Because if you look at some of our young patients and if you look at some data from Queensland, really there wasn't a whole lot of difference between those patients with clinical nodes or no clinical nodes. So in summary, if you have a lymph node disease, they should be removed, and you should perform a compartment-based dissections covering level 2 to 5B. And Deepak commented on this earlier. One of the nodes and group of nodes that are often missed are those within the carotid sheath and within an area called the carotid triangle, which basically is bounded by the scalenus anterior, the scalenus anterior here, and the longest colli muscle medially. The carotid artery goes through it, and the vertebral artery is the posterior extent, and the base is really the subclavian artery. And often these are the areas where lymph node disease might be missed, and you really need to be quite thorough in dissecting that area. The central neck is incredibly controversial. One of the first things you need to understand is the boundaries of the central neck, which extends from the hyoid bone right down to the suprasternal notch and from one carotid artery to the other. One must not forget level 7, the superior mediastinum, which extends from the suprasternal notch to the innominate artery, and is really an extension of the central neck. There is clearly an appetite for elective neck dissection, although it's not called elective neck dissection in thyroid surgery. People prefer to call it prophylactic neck dissection. And it's really favored by those people that do feel that occult nodal disease has a negative effect on outcome, although this is not proven. People feel that occult nodal disease cannot be properly identified in the central compartment with either a CT or ultrasound scanning. There was a paper by one of our local colleagues, Professor Mark Thyroseq, who showed that thyroglobulin at 6 months was lower in those who'd undergone central neck dissection, although really it questions the relevance in a disease that lasts multiple decades. People feel that central neck can be performed safely, and some people feel that clearly reoperation in the thyroid bed is difficult and increases morbidity. However, those people who are generally against performing routine elective neck dissection would argue that micrometastases really have no outcome. There is no level 1 evidence that elective neck dissection has any disease-specific benefit. One of the things that I always question, if we believe that an incident of 50% is significant, why don't we dissect levels 4, 3, and 2? And I guess this is what the Japanese did in the original days. One can perform a CT scan, and this will tell you whether there is clinically relevant neck disease. I do believe, a number of people believe, that elective neck dissection does have higher morbidity, not necessarily in terms of the nerve, but certainly in terms of parathyroid function. And I'm certainly a strong believer that reoperation performed safely in expert hands can be performed with very low risk to the patient. And really, one should reserve elective neck dissection of the central compartment to high-risk patients only. And when you look at some of the literature, and this is a paper from 2018 that looked at a number of papers and again showed that there are significant higher risks of performing central neck dissection routinely, and the effect on rates of recurrence really remain uncertain. So when you look at the American guidelines, there are weak recommendations and low quality evidence to consider elective neck dissection, even in large tumors in older high-risk patients. And there are strong recommendations to not perform elective neck dissection in those very low risk tumors. Upper aerodigestive tract invasion, I'm just going to make a quick comment. As I said, the incidence ranges between 1 to 20%, but I think in routine general practice, it is very much to the lower end. Most commonly, strap muscles are involved, but clearly other parts of the upper aerodigestive tract get invaded, particularly the recurrent laryngeal nerve. And one must not forget that it's not often just one structure that gets invaded, but a number of different structures get invaded together. There is clearly no doubt that this has a significant prognostic effect on the outcome and on the patient. And really the aims are foremost to macroscopically get rid of all the disease, ideally microscopically, but this is often quite challenging. And again, one needs to balance the risk versus the benefits and foremost preserve upper aerodigestive tract functions. I looked at patients with this some years ago with Jeremy Freeman, and we showed that people can live actually for quite a long time with the extrathyroidal spread. And therefore, we must really ensure that morbidity from the treatment is not worse than it is from the disease, and really need to consider quality of life. When we look at the risk of structural recurrence, there are a number of factors that we find after pathologic evaluation, and probably significant lymph node involvement, measuring more than 5 nodes involved, certainly clinical nodal disease, and anything more in terms of extrathyroidal spread, BRAF mutations, and vascular invasion really raise the risk of recurrence in excess of 20%. And generally, these people would all fare best with total thyroidectomy and adjuvant radioactive iodine. But one must not forget how patients respond to treatment. And this is, again, the concept I alluded to that Professor Tuttle has sort of let us know. And if patients have an excellent response to treatment, their chance of biochemical recurrence is actually quite low. If you have an incomplete response in terms of thyroglobulin and certainly ultrasound, then the risk of structural recurrence really goes up quite significantly. And this is something that we need to consider when we are allocating treatment. So overall, the vast majority of patients who present with well-differentiated thyroid cancer have an excellent outcome no matter what we do. We need to balance the risk versus the benefits of therapy, and certainly consider conservative unilateral surgery in those low and intermediate risk patients. I think in today's personalized approach, you need to discuss and at least offer surveillance for incidental micropapillary thyroid carcinoma. There is no doubt that high-risk patients should be treated maximally with total thyroidectomy, consider central neck dissection, and radioactive iodine. There is no doubt that clinical nodes need to be removed, and I feel there is no role for elective, certainly lateral neck dissection. High-risk patients require multimodality therapy, and low-risk patients we can de-intensify. The best approach is achieved with a team approach. We cannot do this in isolation. We need to have a sound understanding of disease processes and practice a personalized approach. I think it is important that anybody that embarks on this surgery has an adequate caseload, adequate training, and participates in continued medical education, audit, and research. Thank you very much.
Thank you, Dr. Kassim Palm, for a elusive talk. So we have a number of questions lined for you. So we will start with the first one. That's from Dr. Yusu. In low-risk, well-differentiated thyroid cancer patients, what type of surgery is best?
It really depends on, if you have an isolated small node, there's not much happening, a small isolated nodule on one side, there's not much happening on the other side. You are dealing with a young patient, a female patient. The needle biopsy suggests a papillary thyroid carcinoma. there is no obvious nodal disease seen on clinical examination or on your ultrasound, I think there is no doubt that in my hands, I would generally offer the patient a unilateral surgical approach, starting off.
Okay. The second question is from Dr. Satyabrat Fukan from Guwahati. Tumor factor or patient factor, which is more important in an intermediate risk patient?
I think it's patient factor. You know, if I have a patient that's male, that's older, and a patient who has a family history, a patient that has a history of ionizing radiation, you know, I would be a lot more concerned, and I would be certainly leaning to a more aggressive and complete operation.
Okay, so question is from Dr. Mayuri Rajpurkar. She wants to know whether you would like to know the physician or institutional factors for choosing against active surveillance or lobectomy.
It's a good question. You know, I think if you're going to have active surveillance, you're going to have a number of things. You've got to have a patient that is happy to live with a cancer. You're going to have a patient who is going to turn up regularly. You're going to have a patient that will be aware of themselves and report any new changes to you promptly. And you're clearly going to have your endocrinologist and your radiologist on board. And you need to have a consistent radiologist. That is, the ultrasound needs to be done by the same department or the same person on a regular basis.
Okay, sir. So if you choose to have an active surveillance, what are the patient or physician factors that make you change your approach down the line?
Well, I think, what physician factors you think?
Yeah, physician or patient factors.
Yeah. Well, the patient factors would be if the patient can't follow up, if they're from a long way away. Certainly if they're uncomfortable with the concept of leaving a cancer in situ. And then if you have a team or an institution that is unwilling to participate, as I said, you know, I think there are a number of opinions in treating anything we do, and we need to have a consensus. You know, we need to have a team approach. This is, you know, we don't treat these in isolation, we treat them together. And if there are any concerns by anybody else, and certainly my endocrinologist, then I'm going to listen to those, and we're going to come to a consensus to make sure that we're on the same page. Because one of the worst things for a patient is to have an inconsistent messaging and a team that is not on the same page. Because as we know, thyroid cancer is bloody hard enough. You know, there are so many ways of treating it without confusing the patient by a team that's not on the same page.
Okay. So we have another question. Do we need to take a relook at papillary thyroid microcarcinoma with size less than 1 centimeter? And do we need a relook at papillary thyroid microcarcinoma in those with less than 0.5 centimeter, especially in some cases of high risk types like hobnail variant?
Yeah, look, I think the reality is that there are always going to be outliers. There are always going to be patients that, and if you look at the data from the Japanese, you know, there are people that progress. There are people that will develop distant, or, you know, distant, rarely, more local regional recurrent, you know, disease progression. But it's very difficult to predict those patients based on other factors. But fortunately, the numbers are low. And if you look at anatomic studies and autopsy studies, you know, the numbers are pretty high in the world. You know, if we have a world population of 6 billion, right, there are 600 million to 2 billion people who walk around with micropapillary carcinoma. And they all get to the age of 110, right? And I think this is the sort of thing that we need to share with the patient. And based on their comfort, you know, we need to allocate the appropriate personalized treatment. So again, I don't think one size fits all, but we need to have a sound understanding of the disease and share that honestly with the patient.
If another question, if central neck is positive, do we need to have to address the lateral neck as well?
Yeah. Look, it depends on whether the central neck is positive in a micropapillary sense, in an incidental occult sense, or the central neck is positive, macroscopically. There are large nodes. But if there was a clinically relevant node in the lateral neck, I would like to think your examination and your pre-surgical ultrasound would have picked that up. Now, Professor Greg Randolph will talk about the use of CT, and certainly he is a huge advocate in using CT scanning on patients with papillary thyroid cancer. I'm not an advocate as a routine because I think the vast majority of people don't have clinically relevant disease. That doesn't mean they don't have microscopic disease, right? But the question is, what's the relevance? And you need to, again, balance the risk versus the benefit.
Okay, sir. Sir, another question from Dr. Devendra Chokar, sir. He wants to know, would you perform a total thyroidectomy for a lateral neck node less than 3 centimeter for a 1.5 centimeter thyroid nodule?
Look, the reality is if you've got a lateral neck node, right, that's clinically relevant, you are, and depending on the patient factors, if you're an older patient, that is significantly going to impact on your prognosis. So the treatment needs to be upskilled, right? In terms of a young patient, they'll be at risk of recurrence, not necessarily a reduction in outcome, but in recurrence. So the thing about treating them with total thyroidectomy up front is just to reduce or improve their disease-free interval and reduce their morbidity from recurrence in the future. So I would probably, with patients with clinically relevant disease, do a total thyroidectomy.
Okay. So again, a question from Dr. Yusu. What is the most common complication in thyroid cancer surgery in your surgical practices?
The most common complication
in your surgical practice.
I don't have any complications. Look, there's no doubt that hypoparathyroidism is something that happens more than we like to admit. Fortunately, I think most of them are transient. So my permanent hypoparathyroidism rate, and I think one of my endocrinology colleagues is online, so he can tell you whether I'm lying or not, but is very low. It would be less than 1% or less than 0.5%. I think a weakness of the recurrent laryngeal nerve, at least temporary weakness, is a lot more common than we think, and we just don't look hard enough, right? And I think that the routine use of nerve stimulation has really focused our attention. And I've certainly been using nerve stimulation for over 20 years. So although my loss of signal and my temporary rate is way less than 5%, it's still a lot higher than sometimes I like to think. And when you look at the parotid literature, right, if you look at facial nerve dissection, if you're honest, a facial weakness temporary occurs in up to 30% of cases. Now, in the facial nerve, because you look at them, they're a bit asymmetric. But often, unless you practice nerve monitoring and routine looking at the patient with nasendoscope, you're not going to pick up the little transient nerve pareses, that occur in the first month or so.
Because of constraint of time, we'll take the last question, which is how often is follow-up recommended if patient opts for active surveillance?
Look, that's a great question. And I have to be honest that although in our institution or in our country, we certainly offer it as a matter of routine, very few patients take us up on it. So to be quite honest, I don't practice active surveillance as a routine. I do have some patients who actually have nerve palsies from idiopathic causes on the contralateral side to a cancer on the only functioning side, and those patients have actually elected to be watched. And these are tumors that are 10 to 15 millimeters, and I've done ultrasounds on them every 6 months. But it's really important to do it at the same place, and make sure you evaluate the 3 dimensions as best as possible in order to get a volume estimation, because you might find that even though certain parameters don't change, some do, and the volume is actually a lot higher than you think. Yeah.
Okay. Thank you so much, sir, for your time. And now we will move to our next talk, which is by Dr. Anil D. Cruz, sir. Is less more learnings from evolution of 2009 to 2015 ATA guidelines for thyroid nodules and cancer. Over to you, sir.
Am I heard?
Yes, sir.
Hello? Okay. If there's someone's transistor radio playing in the background, if they can mute it, please. It's a little disturbing when I speak. Okay, perfect. Good afternoon, everybody. I enjoyed all the presentations today, starting from the first right up to the last one. And I think most of what I want to say has been covered. But congratulations to Akshay and Vishal. We are really proud of you all. You all have taken teaching to a new level. And I was delighted at the number of questions that are being asked. And I think we must pick the brains of our foreign faculty. We normally hear the North American view, and thyroid is practiced differently across the globe. So it's excellent. I just think the last question and answer session was what the whole morning session is all about. Now, basically, I've been asked to speak on is less more, and these are from learnings of the evolution of guidelines. So for those of you all not familiar, there were guidelines in 2009, now 2015, the ATA guidelines, and what really changed. There have been new learnings after 2015, and I might briefly allude to some of those publications as well. Now my slides don't move, and I wonder why this is. Is someone not sharing, or Akshay, can one of you all help me? My slide doesn't seem to move.
Sir, you are a co-host, so you have all the right to move.
I don't know whether I should stop sharing and then reshare.
Yeah.
Stop share. I don't know. It happens once in a way. Share screen. Less is more. Maybe I'll put it in this mode and see if it works. No, it doesn't. It just doesn't. There it goes. I'm going to keep it in this mode then if it's easier this way. Not in the slide share. Okay, I bring you greetings from my new home, the Apollo Hospital. I spent 30 odd years at the Tata Memorial. I now work for the Apollo Hospital Group, the largest private healthcare provider within the country, 72 institutions, over 10,000 beds, most JCI accredited hospitals. I practice in Navi Mumbai, which is the hospital that you'll see on the right, but it's also the first group to put proton within the country. And we've done more than 300 protons, or close to 300 proton treatments within the country for both national and international patients. Now, why is this big hype about less is more? It's predominantly because over the last couple of decades, we've seen a steep rise in the incidence of thyroid cancers. This rise has been predominantly seen in smaller tumors, predominantly in papillary type of thyroid cancers, and the mortality has more or less remained the same. And this rise has been attributed to overzealous imaging. We now have sono, CT, MR. Probably we're just picking up indolent cancers and pushing them to treatment. There were 2 publications from the NEJM addressing this point. The first in 2016 saying 470,000 women and 90,000 men have been overdiagnosed with thyroid cancer in the last 2 decades in 12 countries. USA, Italy, and France were probably the most seriously affected. So overdiagnosed means overtreatment. Korea, a different story. They had a screening program in Korea. where they screened for 5 cancers: breast, bowel, bronchus, prostate. And someone said another $25 and you could screen patients in the neck, put an ultrasound probe to the neck. And the incidence of thyroid cancer in Korea went up to 60 per 100,000. Now, normally in the US and most developed countries, it's about 8 to 11 per 100,000. India is around 5 per 100,000. In Korea, they started picking up lesions less than a centimeter. A quarter of patients had tumors less than 0.5, and these patients underwent treatment. And that's why you see that robotic surgery developed primarily from that part of the world. And you did have complications in these patients, and probably these were indolent cancers and did not need treatment. So in this background, let's look at thyroid nodules and cancer. 4 to 8% of general population have thyroid nodules. You do sonography, 2/3 of patients may have thyroid nodules. And a very elegant autopsy, systematic review, meta-analysis looking at 35 papers, 12,834 patients, looking at thyroid cancer at autopsy for patients who died of other causes. The incidence of thyroid cancer in these patients was 4 to 11%. It would increase depending on how meticulous one looked at the thyroid. And they attributed that really there's no real increase in the incidence of thyroid cancer at autopsy over the decades, thus making a compelling point that thyroid cancer is probably being overdiagnosed rather than a true incidence. Now, there have been papers to counter the view that this is overdiagnosis and there may be a true incidence, but that's not really the topic of my talk. But just in this background, that nodules are common, thyroid cancer is indolent, we all have laboratory cancers living, many of us living with them in our body, and we don't really need to treat our patients. Now, the ATA guidelines changed from 2009 to 2015. The scope widely increased. 2009, there were 80 recommendations and 434 citations. 2015, 101 recommendations and 996 citations. We went from 51 pages to 133 pages. It makes it difficult for surgeons to decide what to adapt. And in brief, I know we all are surgeons. I'm just going to give you my take on the interpretation of literature and what's really changed between 2009 and 2015. So the first, when do you investigate patients? 2015 says for nodules greater than a centimeter. Now, let's look at this across 3 subsets of patients. The first, high suspicion on ultrasound, things like microcalcifications, things like that. In 2009, they said if you have high suspicion of ultrasound, if the nodule was more than 5 millimeters, you stuck a needle into it. That's shifted, and you've heard elegant data in the previous presentations about surveillance. So now, even if you have a high suspicion on ultrasound, you don't stick a needle in if the nodule is less than a centimeter. That's 2015 recommendations. Second, high risk history. That's clinical symptoms of malignancy, childhood radiation, familial thyroid cancers. 2009 said you only stick a needle in if the nodule is more than 5 millimeters. But in 2015, they dropped this 5 millimeters, clearly making a point that those with high risk history, you need to treat a little more aggressively than those with a high suspicion on ultrasound. So really, they pushed the limit to 1 centimeter, telling us that less is more, do less for your patients. But if you have a high risk history, then you need to go after these patients and triage your nodules depending on history. And the third group is picked up nodules. And 2015 says that you're going to investigate all patients who have PET, and for the youngsters in the audience, you all are familiar with the flip-flop phenomenon. If you have nodules that are differentiated, they take up radioiodine. As they become undifferentiated, they take up more of PET. So theoretically, conceptually, we treat PET nodules a little more aggressively than we would treat other nodules. And that's the rationale that the size criteria has been drawn. How does this translate into practice? Now, here is a recent paper looking at active surveillance, and Ito's paper has been commonly referred to, but now there are more and more people across different geographical locations putting patients on active surveillance. So we are going to look at Japan, we are looking at Korea, and we are looking at the US. The blue boxes tell us the number of patients with size enlargement over various time points, and the time points are seen in years on the y-axis. So if you look in Japan, very, very few patients really progressed when they were on observation even 5 years out. Korea was 9.2%, the US, which is fairly recent data, so less than 5% of your patients progress. The number of patients, even if they progressed, who went on to bad prognostic, like say lymph nodes, is very, very low, less than 2%. Japan, Korea, the purple or the violet color boxes. In the US, there were none. And the number of patients converting to surgery changed over time in Japan over 16 years, about 15%. So 85 was still good and under observation. Korea and US, which are relatively newer data, the number of patients who progressed to surgery was much lower. How do you follow up these patients with a thyroid nodule? So remember that the rationale of less than a centimeter to observe comes from active surveillance data across 3 geographical locations, showing you that less than 5% of your patients will need to progress. The number that have nodes will be less than 2%. And as you go out up to 15 years, only about 14 to 15% need surgery. So if you are keeping your patients on follow-up, and these need not be papillary microcancers, it could also be benign nodules, which we see very, very common in our country. In 2009, nodule growth was taken as a criteria to decide whether the patient needs surgery or a re-FNAC. But that shifted to 2015. It's only on suspicious features on sono. Growth rate is subjective. It can vary from sonologist to sonologist, machine to machine, weather to weather, location to location. So it's very subjective. There's lack of long-term data to support growth rate as an important factor that the nodule is turning malignant. And when you compare the false negative rates between these two criteria, the suspicious features of sono is very safe. So we now only use suspicious features on sono. So if you're following your nodule, please look at microcals coming up, taller than wide coming up, extrathyroidal spread coming up. That should tell you that the patient needs to be addressed and an FNAC needs to be done. We'll do the duration of FNACs not before 12 months. So I've seen a lot of patients come with a nodule, not sure whether it's malignant, 1 or 2 signs positive on sonography. They'll say close follow-up and call the patient back after 2 months, after 3 months. Remember that papillary thyroid cancer grows at 1 to 2 millimeters per year. So you calling your patient back very, very often really will not help you in making a decision. And I'm going to share with you an old slide from the World Journal of Surgery. And I've used this slide extensively, looking at the natural history and growth of nodules. 140 nodules followed over 15. And this by and large holds true even today. 13% increased in size. Of them, 26% were malignant. So increase in size doesn't mean all is malignant. 34% were unchanged, 6% were malignant. So a static could also be malignant. 23% decreased and 3% were malignant. So remember that even a decrease in size may have malignancy, and that's why we now look for sono features and not for growth rates. And remember that 1/3 of your nodules will disappear. Cystic nodules more likely to disappear, solid nodules more likely to increase. And this again is a very, very interesting topic and we could discuss, but I don't have time and it's not my mandate today. Now let's look at this in the Indian context. Now, the ATA guidelines recommendation 21 says that patients with multiple thyroid nodules greater than a centimeter should be evaluated in the same fashion as those with nodules with a single solitary nodule. But really, that may be applicable to the ATA, to a Western, to a developed country. There is a threshold size that is pushed out, and that's 2 centimeters for those that have low risk sonographic features. So whenever we evaluate in our country multinodular goiters, don't go sacrosanct by that 1 centimeter and stick a needle in. And I'll tell you why. In our country, if you look at Uni Krishnan's paper 2011, 42 million of our countrymen suffer of thyroid diseases. 12% of our adults have palpable goiters and majority of them are multinodular. So if you use the ATA guideline more than 1 centimeter, you'll be poking a whole load of people who really don't need to do this. And this is very elegantly shown that the ATA guidelines is for a Western population. Here is Yuan Brito's meta-analysis looking at the prevalence of cancer in solitary nodules versus multinodular goiters. So he's an endocrinologist from the Mayo, and he's shown that the risk of thyroid cancer was significantly lower in MNG than in the solitary nodule group. And this is when you look at pooled data across the globe. But when you look and divide countries into US and elsewhere, iodine deficient and iodine sufficient, if you are iodine sufficient and you have multiple nodules, then probably ATA of less than a centimeter, you stick a needle in. But if it's iodine deficient, the incidence of cancer is much, much lower. And here is the forest plot of this meta-analysis. So we would always look at our patients with multinodular goiter and take a decision of not using the 1 centimeter criteria unless they are suspicious sonographic features. So I finish what is known as the nodules, less is more. We tend to observe more patients. We wait as 1 centimeter as a cutoff. In our country with multinodular, no suspicious features, you can push it out to 2. And some of your patients could be even under surveillance if it fulfills the criteria, and that's a different talk by itself. How am I doing with time, Akshay? Is it okay? You told me to go slow. Is it okay? Would there be any questions on this? We could take them, or should I just keep progressing?
You can keep progressing, sir. We'll take the questions in the end. We got time, sir. We got
okay. Okay. The second is lobectomy versus total. Less is more. Maybe now, 2009 to 2015, we've shifted from total towards more of lobectomy, and that's why the word less is more. And this probably is the most compelling change that has come in the 2050 guidelines. Now look at the 2009 guidelines recommendation 26. They said that anything more than a centimeter needed a total or a near total thyroidectomy. But in 2015, they said in properly selected patients found to have cancers less than 4 centimeters, they can still be classified as low risk, and lobectomy alone may be sufficient in spite of having a slightly higher risk of loco-regional recurrence. Now, I want to make a point here that in thyroid, we look for overall surveillance, overall survival when it's an absolutely indolent disease. And we say it's all the same. You may have a slight incidence of loco-regional recurrence. Your patients won't die. But in larynx, which is such an aggressive disease, no one talks about overall survival. They talk about preserving larynx. So I find this a little bit of a paradox. You're not going to lose patients with thyroid on overall survival. So it's a weak endpoint to decide on the kind of treatment that you have. But we've changed. 2009, they advocated more than a centimeter total thyroidectomy. Carl Villamoria's paper 2015, it's less than 4 centimeters. And this data came from various publications after Villamoria. Mendelssohn, Nixon from Sloan Kettering, Adams meta-analysis, not meta, population-based registry. Now look at the number of patients in all these studies: 22,000, 52,000. This Sloan Kettering 889, and Adams 61,000. I want you to focus on this column. Despite all these data, the number of patients who have a total thyroidectomy in lesions less than 4 centimeters across the US is more than 2/3, 73%. At Villamoria's paper, it was 82. Here it's 59 at Sloan Kettering. That's about 60%. And Adam had about 90%. But essentially, there's no difference in outcomes if you do, and that's looking at overall survival. A slight increase may be there in the incidence of loco-regional recurrence, and that's also corroborated from the old Ian Hayes Mayo data that says that there's a 7-fold increase in patients who did not undergo a total thyroidectomy. So we are not killing patients, but we may have a slightly increased incidence. And that's why ATA 2015 recommendation 35B tells us that for patients between 1 and 4 centimeters without extrathyroidal extension and without clinical evidence of lymph node metastasis, you could do either of the two, and they leave the onus on the clinician, and they say a thyroid lobectomy alone is sufficient for low risk when you don't need to give radioiodine. So it's a very, very open-ended. So they push the limit to 4. You can see that 2/3 of patients still undergo total thyroidectomy. Probably we look at more data as it comes along, but the onus is still on the clinician, but a little liberalized, that you can be a little more conservative in your patients. Here is a meta-analysis looking at thyroid lobectomy versus total thyroidectomy. Relatively recent paper, may not be in one of the highest rated journal, but they've looked at 13 studies on subgroup analysis. There may be an overall survival benefit for total thyroidectomy over lobectomy in 2 to 4 centimeter lesions, and recurrence-free survival is also better in total thyroidectomy versus lobectomy. Again, putting doubts in our mind what we should do between 1 and 4 centimeters. So it's really in a state of flux. And I want to tell the youngsters, this debate has been when I was your age, and it will probably continue till I'm in the grave, but we know how to treat, we need to know how we treat our patients. Now, here's the paradox if you start observing patients between 1 and 4 centimeters. And I've just put up 3 papers, one from our country, from the Amrita group, and I can see Deepak, part of the faculty. Samskruti, who led this paper, is also part of the faculty. And 2 other papers that I've put up. One is from Orlo Clark's group, the second one, just to make a point that when you operate patients between 1 and 4 centimeters across various publications, I could have put up more, 20 to 60% will finally come with final histology, which will be intermediate grade, and you may have to convert into a total thyroidectomy. So keep that at the back of your mind. Many of the youngsters look at 4 centimeters, say 3.8, and they say, no, ATA says do a hemithyroid, and they do it. Remember that 2/3 you'll have to convert into a completion thyroidectomy. So what do we do in practice? If it is less than 55, I put 45 to 55 because 55 is one of the new recommendations. Purely less than a centimeter, intrathyroidal, a very favorable histology, unifocal, absence of distance and nodal metastasis. I've not put the molecular because we don't do it. We'll do a hemi. If it's more than 4, gross extrathyroidal, aggressive variants, multifocal, nodal metastasis, distant present, we'll always do a total thyroidectomy. The debate comes between 1 and 4 centimeters with no high-risk features, and the pros and cons, as said in the ATA, have to be discussed with patients. Keep at the back of your mind, you'll have a higher incidence of locoregional recurrence. Up to 2/3 of your patients may come back with bad risk features to have a total thyroidectomy later. And remember, across all major publications of up to 60,000 patients, 2/3 to 3/4 have gone ahead and had a total thyroidectomy. So whatever we say at meetings, a lot of clinicians still do a total thyroidectomy between 1 and 4. But yes, if it's a 1.5, 1.8, comes with a hemithyroidectomy outside, I will not rush in to do a completion thyroid if the other features are negative. But if I have a patient in my practice who comes to me de novo with a 2.5, 3 centimeter nodule, there will be a tendency on my part to go over a total thyroidectomy. Personal views, and this is what the majority of people do. And I've shown you compelling data of 60,000 patients where 2/3 of them have undergone a total. I've shown you Memorial Sloan Kettering data, which is such a strong proponent of lobectomy, where 60% of patients less than 4 centimeters did have a total thyroidectomy. What do we do for nodes? So basically the recommendation between 2009 and 2015 is more or less the same, that you must do an FNAC for suspicious nodes. But now they've brought in a size criterion of 8 millimeters. So just as our previous speaker said, we are not going to be very aggressive for a 2 millimeter nodule going and poking it and things like that. Generally 8 millimeters is considered as the threshold. Now again, don't take this as sacrosanct. It could be a centimeter, it could be 6 millimeters. It depends whether it's primary, whether it's in the recurrent setting, but don't be aggressive. The problem is less is more. Be conservative. Don't be aggressive to charge into the central compartment if you're not sure of the pathology of the nodule and it's very, very small. And that's because you have to weigh the benefits versus the morbidity. The central compartment is the first echelon of nodal spread. It houses the recurrent and the parathyroids. You may have nodes present even when the nodule is small and intrathyroidal. Micrometastasis less than 2 millimeters may approach 90% depending on the detection method used. And lymph nodes, by and large, do not have a detrimental effect on survival. But there is sheer data to show if it's associated with T3, T4 tumors, even if it's micrometastasis, aggressive histology, or in people more than 45, you could have a detrimental effect. So again, have an open mind and use what you want to do on the neck, not because there's no benefit, you don't touch the neck and there are few nodules that you leave behind which are less than maybe 5 millimeters, 3 millimeters, saying that ATA said 8 millimeters. So you need to triage, make a balanced decision of how you want to treat your patients. And I'm going to show you this paper from Sloan Kettering, which tells us that the size of the nodes or treating or just aggressively going after the nodes really doesn't make a difference. Published in Surgery 2013, looking at over 1,000 patients of total thyroidectomy across a very long time span. 275 had no nodes removed. Follow-up 70 months, disease-specific survival was 100%. And the rate of structural recurrence in the contralateral neck was 0.4%, and the rate of reoperation was 0. So just making a point, if you don't see gross nodes, you don't have to go in and do a very strong central compartment clearance and risk the parathyroids. If it's not seen, probably it's not going to cause a survival detriment to your patients. There are advantages for and against treating the neck. Some people say improve DSS, you can follow thyroglobulin better, it facilitates radioiodine. Others say you have an increased hypocalcemia and recurrent laryngeal nerve. Let's see what data says. Here are all the meta-analysis published to date. Really, there is an increased morbidity of hypocalcemia. Majority of them are temporary. one or two of the studies saying that there is a decreased locoregional recurrence and it could be safe in high volume centers. So what message do I give the youngsters? If you're an adept thyroid surgeon, there's no harm peeking into the central compartment. I know there's data that surgical assessment isn't as accurate and you may miss microscopic nodes, but I made a compelling point that it's microscopic. If you cannot see it, it's unlikely to cause a structural problem for 10 years. And I showed you Ian Nixon's paper. But if you see nodes there, it's not that you say that central compartment is not to be done. There's no compelling data. Remove the thyroid and close your eyes in the central compartment. Please take a look. And if you see those big black shorty nodes, 3, 4, 5 millimeters, you know it's PAPCA. I would go ahead and at least clear the ipsilateral central compartment. And these are not for proven metastasis in the central compartment. So the central compartment in my book would always be explored. We'll do a neck dissection when it's node positive in the central compartment for advanced tumors T3, T4. And when the clinical nodes in the lateral neck are positive, because 80% of lateral neck will be associated with central compartment disease that varies according to the situation of the nodule within the thyroid. What happens when patients recur with nodes? Again, the ATA uses the size criteria of 0.8, it should be 0.8 centimeters, I apologize, 8 millimeters. So again, when you're following up a patient with a thyroid, having had a total thyroidectomy, you see a 3 millimeter nodule in the central compartment, you don't have to get panicky. You can observe that, and Mike Tuttle and others have had large series where they're following patients with time and really no detriment. The rationale of observing these patients is that morbidity of resurgery is high. It's often difficult to locate a 3 millimeter lesion, 4 millimeter lesion. You'll have a nodule, someone will stick a needle in it to say PAPCA. You're going to operate in a fibrous neck, you won't find the node. It's very embarrassing to come out and tell the patient you operated and you couldn't locate the node. Again, topic of discussions. There are methods by which we can do that, but we'll discuss it on some other day. And the last is that many of these nodes don't grow at all. For the lateral neck, a 1 centimeter criteria is used. So again, youngsters, when you follow your patients, even if they've had a neck dissection, you will see rubbery nodes coming up at level 5 and all. You don't have to get very aggressive going to FNA them. 1 centimeter is the threshold. Only if it then causes a problem or sono features, then we would do it. Akshay, I've got a few more slides. Should I go on or should we stop here? Because the rest is non-surgical.
I think I can proceed, no problem, sir.
Yeah, it will be
Okay.
useful for us.
Okay, I promise I won't be, it's not 29 or 50 as seen at the edge of my screen. I've got many slides after the thank you in case there are questions. Okay, the next modification is the, in 2009, they had what is known as initial risk stratification. It's modified now to modified initial risk stratification. And this is figure 4, and I think it's table 11 or 12 in the AT, and youngsters, you must see it. And I think the previous speaker also put this up, classifying patients into low, intermediate, and high risk. And the change is that this is dynamic. So you need to assess your patient's risk over time, temporal relations. So it's once you're in a low risk, or say, let me say the other way, if you're in a high risk, nothing happens to you for 4, 5, 7, 10 years, you can come to intermediate risk and be less aggressive with your patient. So less is more. That means decrease L-troxin, which I'll show you in the next couple of slides. So the change is that it has become modified initial risk stratification and it is dynamic. We are trying to do less. Plus, we have expanded the definition of low risk. So small volume lymph node metastasis less than 5 or nodes less than 2 millimeters are not taken as high risk. So those are taken as low risk and you may not want to treat your patients further. And while microscopic ETE into the perithyroidal soft tissue is intermediate risk, microscopic ETE in small tumors may not need RAI. So we're basically now doing less by expanding the scope of low risk. And the two important factors we are taking is lymph node metastasis and microscopic ET. Greg Randolph will show this in the evening today, but I just to consolidate the point I'm making, a seminal publication, and then there have been many subsequent publications. If you are node negative, your recurrence rate is 4%. But if you are node positive, the recurrence rate is also more or less the same, particularly when the nodes are less than 5. So this is the important point. But when you have more than 5 nodes, the recurrence rate jumps. And that's why less than 5 is taken as low risk. Anything more than 5 larger nodes, extra nodal extension, places you in high risk. So again, youngsters, when you read a histopath report, 2-3 nodes, less than 2 millimeters, no extrathyroidal spread, I don't push my patient into radio iodine. Extrathyroidal spread does classify into intermediate microscopic into the perithyroid. Here is Sloan Kettering data again. Here Nixon led this paper. Nearly 1,000 patients with T1, T2 disease. 115 were upstaged to T3 on microscopic ET. And they had different treatments, total thyroid and a lobectomy. Now look what happened. Even though they had microscopic ETE, there was no difference in 10-year overall survival, disease-specific survival, recurrence-free survival. No p-value significant. And the only thing that in these PT3, that even the extent of surgery, the histology, and the need for RAI, whether you gave it or not, did not make any difference. So we are going back into less is more. Nodes, small, low volume, low bulk, low risk, continue to observe. Don't go pushing your patient into radioiodine. And exactly the same for microscopic ET. If the tumor is small, you have a 4-centimeter tumor, you have microscopic ET into the perithyroidal tissue, I would then treat that patient as intermediate and give my patient radioiodine. Radioiodine, again, we are doing less is more, fewer patients, lower dose, exactly the same criteria of 2009 and 2015, low risk, avoid RAI, intermediate risk, consider RAI, high risk, definite RAI, but we are expanding the indications of low risk and therefore fewer patients get radioiodine, and I told you ET and lymph nodes most compelling. And the second is the doses. We used to do RRA, which is residual remnant ablation of the thyroid. In 2009, they said that you can give between 30 and 100 millicuries, but now it's been pushed in section 55A in the 2015 guidelines that it's exactly the same, and many people go for much lower doses of 30, and there's compelling level 1 evidence to also prove that this is fine. So it's never 30 to 100, it's now low dose radioiodine. So we're treating lesser patients and we are giving lower dose. And also ATA says that empiric high dose for aggressive disease should not be upwards of 200 millicuries, which was recommended in 2009. It's 150 millicuries, particularly in elderly patients. Remember, you get radioiodine refractory disease when you go upwards of 600. It's not 1 curie anymore. So you want to hold it back, give 150 millicuries. So we are treating fewer patients and giving lower dose. Now remember that thyroid cancer is TSH dependent, and TSH suppression was very important. So we gave and we keep the TSH between 0.5 and 2 for low risk, between 0.1 to 0.5 for intermediate risk, and for high risk, we gave less than 0.1. Now remember that when you give eltroxin, for every five patients, you have 4 are females. And many of them, when you give eltroxin, you're trying to push them into premature osteoporosis. If you keep the TSH too low, as it is, estrogens are dipping and their bones are getting weak. And then you give eltroxin, you're pushing them into premature osteoporosis. Plus, L-troxin increases cardiac output and not good as your patients get elderly to have an increased stroke volume. So 2015 says you don't have to suppress L-troxin very, very aggressively. You do suppress according to the risk category, but we now aim for the higher level of the range, like 0.5. We are not going towards 0.1. We are not going against 0.5. We are going more towards 2. So we've become a little liberal. And plus, we don't stop and get a stimulated thyroglobulin, which was recommended in 2009 guidelines, which even in low risk said 12 months post scan, you would go ahead and do these stimulated thyroid globulin. The rationale is changed. And the reason is we got newer assays for thyroglobulin. They are ultra sensitive and they overcome that stimulated benefit is offset. So now we are not pushing patients into absolute TSH suppression and taking them off L-troxin or giving them recombinant is really not required for the low to intermediate. We could observe with ultra sensitive TG assays. I'm ending with my last 2-3 slides. Less is more. Remember that differentiated thyroid cancer does not kill in the vast majority. So youngsters, please don't go and do an aggressive total thyroid, have a cord palsy patient on 14 tablets of calcium, because you're not going to kill your patient, but the patient will curse you all the life with these complications. So the first thing is do no harm. And I've shown you elegantly that up to 4 centimeters, you can still consider a lobectomy. You may want to not be very aggressive in the central compartment. You may want to have someone senior who does more thyroids with you, because thyroid complication depends on the volume of work that is done by the surgeon. So please keep that at the back of your mind. And remember that guidelines are not sacrosanct. If you read the ATA guidelines, for the majority, it's moderate evidence, weak recommendation, moderate recommendation, because we don't have level 1 data. When you treat your patients, it should be individual decision making. It should take the patient and family into consideration and use their preference. You must use clinical judgment. So like I told you, if you have a large nodule, perithyroidal soft tissue, microscopic, I'll probably do total and give radioiodine. But if it's a 1 centimeter nodule with perithyroidal microscopic, I won't push the patient into intermediate. And remember their geographic variations. Western data may not be applicable to our country, like I showed you for multinodular goiters. And for various other things, many of our patients are not incidentally detected. They come with a 2 centimeter nodule, and we are treating the true increase in thyroid cancer patients and not patients who are incidentally detected. Remember, in the US, Davis's paper showed that 86% of patients were less than 2 centimeters, which still is not the case in our country. And there's so many guidelines, just so many. But all of them say less is more. Be a little conservative, no morbidity for your patients. Your patients are not going to die, but choose your patients correctly. I'm ending with this very common, lovely saying by Blake Addy, which I love whenever I speak on thyroid. Biology is the king, selection is the queen, technical maneuver the prince and princesses. Occasionally, the prince and princesses try to usurp the throne. They always fail to overcome the powerful forces of the king and queen. Individualize your patients. Don't, very often when I round, people will, but ATA says this. You need to individualize. Look at the biology and select your patients correctly. And the main factors we look for is histology. If it's an aggressive variant, we look at the age. We look at extrathyroidal spread. More importantly, gross, but microscopic if nodule is big. Presence of metastasis, nodes, and distant metastasis. And if you do mutational factors, then the BRAF and the TERT and the various other mutations that would guide my philosophy of when I want to be aggressive. Otherwise, I would err on the side of causing my patient less damage, and that's why the title less is more. Thank you for your attention. I know I may have overshot my time, but Akshay this morning told me speak a little longer because one of the speakers is not there, and that's why I did it. So for those of you all who are close to lunch and are cursing, Akshay is the guy you'll have to blame. But thank you very much for giving me this opportunity, and congratulations to Vishal and Akshay once more. I'll be happy to take any questions, and if there are any other comments, I would encourage my co-faculty today and some of the senior faculty in the chat room to also be unmuted and make their comments.
Thank you so much, sir. Sir, as
Maya, can I ask a question to Anil, sir?
Yeah.
Anil, sir, there have been various recommendations regarding the size criteria for a redo thyroid bed operation in patients who have completed their surgery and radioiodine treatment. Do you use any adjuncts like charcoal tattooing or pink and blue? And what is your philosophy in identifying the nodule in the thyroid bed if it's a centimeter or more?
Okay, so basically what I would do, and I'm going to tell this again for the youngsters, because very often when these nodules come back, they are referred to higher centers and it's not going to be in your practice. But I'm going to tell you the philosophy that I do to identify disease. And this, I'm just extrapolating your thing about looking behind the vein for certain things. So what I do is always, before I go into any thyroid surgery, however small, I am very aggressive in mapping the extent of disease. So it will be an ultrasound, except for the tiniest lesions, there will be a CT scan as well. And that's to map out the nodal disease and central compartment disease. Ultrasound is good, but it's operator dependent. Ultrasound is not very good in the central compartment when the thyroid is in situ. Ultrasound is not good in sites such as nodes going towards the mediastinum, parapharyngeal nodes. I saw some questions coming up, parapharyngeal nodes. So here's what I do. I always will have the ultrasound and CT, and there's enough data to show that both the sensitivity and specificity increases if you use both modalities. So I would map this disease out nicely. I would have the roadmap before I go into the neck. Usually my threshold is not 2 millimeters, 3 millimeters, 4 millimeters. It will be towards the 88 millimeters, unless I feel this is very close to the recurrent laryngeal nerve. If I have operated before, I know the anatomy well, in that case I would go in. To find out a node that I'm not able to find at surgery, and honest to God, and I'm not trying to blow my trumpet, I usually, when I go in, will find the node. But when we were at Tata's, I know that many of my colleagues would do intraoperative ultrasound to locate nodes that were seen earlier and not found at surgery. So in our book and in our experience, what I would do was intraoperative ultrasound. We would not do the charcoal tattooing. Some people have even described giving the isotope and using a gamma camera to pick this up. But those are all within the books and really not very practical in our practice. I don't know if I've given a very verbose answer or it's okay, Deepak.
That is fine, sir. The second thing I want to ask you is that does the level of thyroglobulin influence you to go back and redo a thyroid bed recurrence? If the thyroglobulin levels were not much compared to the previous values, would you wait and watch the thyroid bed recurrence?
Yeah,
or is there a cutoff that you personally believe is important to go back to the thyroid bed?
Yeah, so again, if you read ATA guidelines and if you look at, I would say again, there's nothing sacrosanct. I would use a combination of patient factors. That means how often the patient will follow up, where the recurrence is. If it's bang in the center over the trachea, I know the recurrence are not at risk. I would do my radiological assessment of increase in size, plus I would look at the thyroglobulin. So let's say if a patient has a thyroglobulin that suddenly increases, say the ultrasensitive to more than 10, and I think ATA have given cutoffs of 5 and 10. 10 for withdrawal and 5 for recombinant TSH. And that is an indication to give radioactive iodine. Now, generally we believe, now I'm going to make this a little convoluted, but I kind of put all these factors together. Thyroglobulin, 1 gram of thyroid secretes 1 nano ml of thyroglobulin. So if I have a sudden shoot up in thyroglobulin from 2 to 15 and my nodule size has not increased, I'm not going to go like rushing to take that nodule out thinking that's the cause. I will have a diligent investigation of the rest to find out whether there's any other site of disease. Again, usually a high resolution ultrasound is good because 70% of nodules which recur or cause a rise in thyroglobulin will be above the clavicle. So I'll really have a very diligent examination of the neck. But yes, it will be a combination of radiological increase in size, patient factors of follow-up, location of the nodule, and thyroglobulin increase, which will make me go into to operate my patient.
And pardon me, sir, for the last question. Would your philosophy change if this was a tennis patient who's radioiodine refractory, who has a thyroid bed recurrence? Would you change your indications for exploration of the thyroid bed?
Yeah, so a tennis is basically thyroglobulin elevated negative iodine scan. The first step in these patients is to do a meticulous ultrasound, high resolution. Locate disease and you can go in and operate depending on the philosophy of slice criteria and where it's located. Again, I mean, usually when you have a tennis with a high thyroglobulin, you'll see fairly big nodes somewhere and you'll need to go in. We usually won't have a tennis and we won't be observing the patient. But there are two points I want to make on tennis. One is 70% will have disease in the neck. So if your sonologist doesn't find it, send it to someone else who has more experience, not to undermine anybody's technical competence. Always do that in tennis. And second, when I was younger, had this idea of sending them to the RNC, which is the Radiation Medical Center, and give them empiric radiotherapy. Now that is more or less outdated. We don't do carpet bombing anymore. It's all very, very specific. We localize disease, and if it can be surgically taken out, surgically taken out.
Okay, sir. Thank you so much, sir. Thank you for the organizers for letting me ask these few questions. Thank you, sir.
Thank you, sir. Sir, there are a few more questions lined for you, sir.
Anybody else wants to ask?
Yes, sir, one question is from Dr. Yusu. She wants to know, how does it take to get representative sample for FNAC?
Oh boy, you mean on a nodule? First tell me, where is Yusu from? I find that name very fascinating. Is he from Taiwan or where is Yusu? Maybe we can have Yusu type in the chat box. I saw he or she, I apologize, I've never heard that name before. It has been very, very active. I wonder whether Vishal and Akshay can give them a little, people who have been active in the chat box and asking brilliant questions, a little token of appreciation, like a small prize, maybe, like a book, maybe Greg Randolph's book. But anyway, Yusu, again, if you look at ATA guidelines, FNAC should always be done under ultrasound guidance. But remember what I told you, 86% of patients in the US have nodules less than 2 centimeters. So to localize that small nodule, you need ultrasound guidance. Ultrasound guidance has an incremental benefit of 5 to 10 to 13% depending on the paper that you use. You read to avert a false negative or a Bethesda where you don't, which is non-diagnostic, Bethesda 1. So you'll always do it under ultrasound. Second, you will always use a fine needle. It's paradoxical. People believe that if they put a bigger needle in, they'll get more tissue. Bigger needle will get you more blood. So you will always use a fine needle aspiration cytology. It will be a needle of 23, 24, 25 gauge. That is point number 2. Point number 3 is don't put too much of traction on your plunger. sometime for vascular lesions, and that's not only in the thyroid, elsewhere in the body or any vascular, you can just put the needle in and use the plunger. Don't use the plunger, just the needle on the syringe, and poke it in so that you don't get blood. Then take out the syringe, suck in air, and then squirt it on the slide. And lastly, you must see 6 clumps of 10 to 15 cells to call it representative. So I don't know if this has answered the question. So ultrasound guidance. Now ultrasound guidance in our country sometimes becomes difficult. But if I see a 4 centimeter tumor in the neck, I would just do the FNAC in my office rather than send them to a sonologist. So I think you just need to adjust to your kind of practice. And the fifth point, I think that's very, very important, you must have adequacy testing. Many of us can squirt it on the slide, hold it up against the light and look at particulate matter and say you've got thyroid follicles, and you can say when it's blood. Many people with experience can say that. Some of the guys I worked with in Tatas could even look at the slide and tell me what was the diagnosis, whether it was medullary, but I didn't have that kind of gift, but I could at least tell them that there was particulate matter and okay. But now the current thing is that you have adequacy testing. So you have a cytotechnician sitting next to you, puts that little slide under the microscope and tells you, yep, it's representative, won't give you a report, the senior pathologist will report subsequently. So that's the fifth thing that you would use.
Thank you, sir. Sir, one more question from Dr. Mayuri.
Oh, Mayuri does say adequacy. She kind of read my mind. She's another girl I recommend for a prize. Huh? She's always been active on every webinar.
Yes. So she asks, what are the indications for a near total thyroidectomy today? How do you follow up these patients? Same as after a lobectomy? Or what are the absolute indications for a completion thyroidectomy?
No. Now, who asked this? Mayuri?
Yeah. What are
Did
the
Mayuri
indications?
ask this?
Yes, sir.
Okay, listen, this is a very moot point. If you read what is known as the ATA or any guidelines, usually near total and total are used interchangeably.
Okay.
So why do you use a near total? I know there are many people who come from North America and say if you are doing near total, then you're not worth doing a thyroid operation. But I don't say that at all. You're aiming for a total thyroidectomy. Very often, given the patient's anatomy, patient's body habitus, depending on your mood, sometimes it's oozing all over. That little nubbin of tissue at the point of entry of the recurrent laryngeal nerve is very, very difficult to take out. And you know that is normal thyroid tissue. Don't be very aggressive that it's hurting your ego and you're going to go and take out this nubbin of tissue and fix the nerve. In that case, you leave back that little nubbin, which is small enough for the person to ablate. But by and large, you aim for a total thyroidectomy. So the majority of us with good experience will be able to do a total thyroidectomy. But occasionally, if you have to leave back a little nubbin, and we all have done it hand on heart, and even if you do a radioisotope scan in the best of centers, isotope pickup will be there between 10 to 30% of patients, even if they call it a total thyroidectomy. All the patients will not be without isotope pickup. So I'll do a total thyroidectomy. Now say I've done a patient with a cancer of 2 centimeters. I've done a total thyroidectomy. Opposite lobe has a small nodule, not sure whether it's malignant. That's my indication for a total. I'll wait for histopath. If it comes in low risk, I won't give the patient radio ID. If it comes in intermediate or high risk, I'll give the patient radio ID, and then with my dynamic risk stratification, follow my patients accordingly.
Okay, sir. Thank you, sir. One more question from Dr. Kudus Ahmed. Do all tennis become radioiodine refractory, or is there a subset that are radioiodine sensitive?
So by and large, tennis is radioactive refractory, but Kudush, I told you 70% of your recurrences come in the neck. Now, if you remember your basics of physiology, in the neck, if they recur, they usually recur in the neck nodes. So if you were N0 before, the chances of recurrence is 5%. If you are N positive, the chances of recurrence are 20%. 1 in 5 will recur in the node. Now, these nodes do not have the sodium iodide symporter. So you will not be able to, so they're not radio refractory, radio iodine refractory, but nodes do not have a potential to take up radio iodine. So those patients have to be treated surgically. So they're not radioactive refractory if they're in the nodes. But the majority of other patients would probably not have iodine pickup. And that is one of the criteria. Most of these patients, if surgically excisable, would undergo surgery.
Okay, sir. Thank you, sir. Sir, Dr. Akshay wants to know thyroid node management in pregnant patients.
Boy. So, but Akshay, you need to tell me whether the nodule is malignant or non-malignant. If it's benign, just wait, just let it be. Remember that the thyroid increases in size during pregnancy. One, because of the increased physiological need and increased blood flow, and plus, if you look at the structure of the HCG molecule, which is the human chorionic gonadotrophin, and the TSH molecule, the initial parts of the structure are very, very same. So there are two reasons why the thyroid increases in size. So even if it's malignant, there may be a slight increase in the size of the nodule. I will not rush in to operate that patient unless they are high-risk features. Now remember that the baby does not have a thyroid, or the baby's thyroid or the fetus's thyroid doesn't function till 16 to 18 weeks, totally dependent on the mother. Organogenesis is in the first 3 months. So I'd probably not operate in the first 3 months. As I go towards the end of the second trimesters, when I operate patients, if I operate in the third trimester, premature delivery is very, very common. So triage of patients, those with high risk, will come into surgery at the end of the second trimester. But I can't generalize this. It also depends on the makeup of the patient, age of the patient. Makeup, when I said, I mean psychological makeup, not the external makeup. The age of the patient, whether the baby is a precious baby or not. If I have a 35-year-old physician who came to me, she's pregnant after years of trying to conceive, I'd probably do everything to hold on to that pregnancy. And I may not operate to very much in a hurry, unless they're high-risk features. I stick a needle in, it comes as an aggressive variant. Then, of course, I'll take the chance and go ahead and operate, preferably towards the end of the second trimester.
Okay, thank you, sir. Last question. What is the significance of N0A and N0B as per AJCC 8 staging, and what is the basis for this staging?
I think the previous speaker, Carsten, should be answering this. Mine was just a change between 2009 and 2000. And anyway, I will quickly tell you again, please remember that in lymph nodes, this is the only cancer in the body where age and lymph nodes do not have a detriment outcome in patients. So don't get too very, how should I say, concerned about this A and B business. So here's what I will tell you whenever you're treating with nodes. Remember that nodes don't have a detriment in outcome, except if it is associated with high risk features. High risk features means age more than 45, aggressive histologies, or large volume of lymph nodes. The second point about lymph nodes, please remember that lymph nodes, if they are positive, they will recur more often. So do your dissection very meticulously. Don't do it when you have to take your wife out in the evening on your wedding anniversary. Spend your time mapping out the disease and take out every flat globule. The incidence of your recurrences will be much less. And as Deepak said, there are certain areas where the nodes really hide, and they have that kind of problem. So please go ahead and operate your nodes very, very carefully. It does not have an impact on survival, and that would be my philosophy of managing neck nodes, rather than looking very, very categorically at the TN teaching. But if you wanted to have any particular answer or any particular doubt between A and B, maybe you can focus your question a little more better, and I'd be able to
I mean, I'm happy to answer that.
Yes, sir. Please continue, sir.
Look, I think that's a bit of a strange staging, and I don't really 100% understand it. And I think Dr. De Cruz has really just articulated this incredibly well. I actually think for the vast majority of thyroid cancer patients, there is a complete and utter overemphasis on the nodes. Thyroid cancer is not upper air digestive tract squamous cell carcinoma. You know, it's not oral cavity cancer. It's a disease where we have to be a lot more circumspect, where we can do a lot more harm. And I just think this complete and utter overemphasis is really to the negative of the patient, you know. I mean, that's why you look at thyroid surgeons, they don't even call it elective neck dissections anymore. They call it prophylactic head and neck dissection, right? Neck dissection. I mean, to a head and neck surgeon like Professor De Cruz, you know, I'm not sure whether you share my same feeling, but that's not really, I mean, a term that I would use.
Thank you, sir. Sir, one last clinical question has come up by Dr. Shaima, AP. She had one patient underwent surgery 10 years back and now again presented with a thyroid swelling. Thyroid function test is normal. However, FNAC shows a Bethesda 2 with follicular background. Patient has pain over the swelling with extreme tiredness. How to manage?
Say that again. So she's a lady who
Yes,
has a thyroid nodule. It's a Bethesda 2. And
was
then
operated 10 years back. And now she presented with a thyroid nodule with Bethesda 2. Thyroid function test is normal. Patient
no,
has
but what was she operated for?
thyroid swelling only. 10 years
I didn't. So she had a goiter and she had a hemithyroidectomy on one side. Now she's come back with a nodule on the other side. And the thyroid functions are normal. It's Bethesda 2, and she has pain and she has tiredness.
Tiredness, yes, sir.
So in my book, you don't operate a thyroid nodule for pain, and you don't operate a thyroid nodule for tiredness.
Okay.
So there has to be some other factor. But if the lady is middle-aged, very often it's associated with thyroiditis. So I would go ahead and do thyroid. I would do thyroid antibodies in this patient. And if the thyroid antibodies are up, I treat symptomatically anti-inflammatories, counsel the patient, plus minus steroids, and then decide what I want to do for the patient. But I'm definitely not going to operate the patient for pain or for a feeling of tiredness. That's not an indication to operate the
I think you need to take a good history.
I just keep the patient and follow up if sonographic findings. Say that again.
I think you need to take a good history and a good thorough head and neck examination, because the nodule's not causing the problem.
Yeah, but it's also the problem may not be with the patient, Carsten. Maybe the spouse is troubling the patient. It could be psychological. it could be something else. I'm not sure in my head and neck practice I'm going to have a patient who comes with tiredness and pain in the region of the.
Well, I usually tell them I'm more tired.
Tell me honestly, hand on heart, apart from thyroiditis, what? Yeah, true, very true.
Thank you so much, sir. Thank you all the speakers for sharing their knowledge with us. Now,
before we wind it up, I think there is one question with Dr. Deepak Damodaran from MBR Cancer Center wanted to ask. So his question is, what is the incidence of inferior parathyroid being detected when you do a central compartment neck dissection? And if at all you have to do a central compartment neck dissection, how do you manage the incidental chance of removing the parathyroid? How do you manage that situation?
Does Carsten want to answer it? Because I just spoke on this at the HCG meeting. Maybe we can get your views. I can chip in with something if you want me to do it subsequently.
Sure. I mean, I think you find the parathyroid like you do in any thyroid surgery. You know, you've got to have a sound understanding where that parathyroid is, and you should actively look for it. And, you know, and if you see it, you take it out, you take a sliver to confirm that it is parathyroid, and then auto-implant it, you know. I think, you know, there is a significant elevated risk of having parathyroids in your lymph node tissue. So the reality is, yes, you've got to look for it. And the best way to prevent problems is to look for it, find it, auto-implant.
So,
I would, any great,
yeah, sorry, go ahead. Sorry, apologies. Go ahead.
No, I'm just saying, I don't think there's any great magic. I think, you know, you've just got to look and find it, you know. I mean, if you don't really have a huge amount of lymph node disease, it should be in the normal position. One of the problems is if you've got very bulky nodes, or you've got a very bulky tumor on that side that can displace it, and therefore it's going to be at higher risk.
So I'm going to give you 2-3 tips that I tell my youngsters. And I think the first speaker very nicely spoke on anatomy. And I know people normally don't listen because they think that they know all the anatomy. So here's what you do. And I agree with Carsten that it's always when you have bulky central compartment neck. So if I operate a patient with multiple lymph nodes in the central compartment, I tackle the less involved side first. I locate the inferior parathyroid, put a clip on it. And like our first speaker told us, 70% of times it will be in exactly the same position on the opposite side. So now when I do my central compartment, I kind of have a roadmap where that parathyroid will be amidst these lymph nodes. And if I can see it, I'll save it. If I can't see it, there is again data that your incidence of hypocalcemia increases depending on the number of parathyroids that you see or you don't see within the body. So now if I've not seen the inferior parathyroid, I will sit with the specimen before it goes out into the frozen room while maybe the assistant is doing something else, doing the lateral neck, or I will ask them to sit with it and gently tease out node by node and look for the parathyroid in between. And if I find it, confirm it on frozen and implant the rest into the body. So I think those are the 2 tips that I would give in addition to what Carsten has said. I totally agree with what he said.
Maya, can I add something with the permission of the other speakers?
Yes, sir. Yes, sir.
I mean, the key is super selective ligation of the inferior thyroid artery. And the inferior thyroid artery has to be ligated as close to the capsule as possible. Because the inferior thyroid, parathyroid is at a variable position. Even if you say it's 1 centimeter around the radius of the inferior thyroid artery, it can be at a variable distance. So my principle has always been identify where the inferior thyroid artery enters the thyroid gland, clip it. So it's super selective clipping of the inferior thyroid artery. And the superior thyroid artery is always above where the recurrent nerve enters the cricothyroid junction. So I would be very, very close to the thyroid capsule when I'm dissecting. And sorry to say, in my practice, the central compartment dissection is not very continuous. Because I know that...
is not very?
Continuous.
Right.
I mean, you don't get that fascial sheet like you do when you do a lateral compartment neck dissection. Because you're left with individual sites to pick up the fascial layer. And you say juxtapositional to the lymph nodes and then you resect it. But if you find a revitalized parathyroid, you always implant it into the sternocleidomastoid or the strap muscles, and then it's only a temporary hypercalcemia. But the basic funda is that you stay...
Deepak,
sorry, sir. Please go ahead, sir.
No, go ahead. I'm sorry. Maybe your voice broke, so I thought you'd finished. I want to make 2 comments when you finish. Sorry, just go ahead.
Please make, sir. I'm done. Please make,
So,
sir.
I think we all do capsular ligation, but I want you to Google at the end of this talk. There's a lot of data to show that even truncal doesn't have an effect on the parathyroid hypocalcemia. Please look at it. I know I also teach capsular, so I'm just keeping that open. It's about seeing your parathyroids and preserving it. So there is a school of thought that doesn't agree with this, but this is a teaching thing and they're youngsters, so I just want to do it, but I always advocate capsular. And the second thing is, while I agree with you about these facial sheets, but don't try to divide your central compartment away. Try to do it in continuity.
It should be, sir.
Yeah, those last nodes going into the mediastinum, if when you have this chain of lymph nodes and you give traction, it's easier to get out those last nodes. If you divide it and then they sink
and then you stop with
back into the mediastinum, you'll get them out, but it won't look elegant.
Once you see the thymus, you cut short and then you pull out the lymph nodes. But juxtacapsular dissection is probably the best way to prevent hypocalcemia in the setting of no central lymphatic lymphadenopathy. And you need to use a loop. I use a loop a lot. I mean, I use a loop every time. And then it really makes a difference in identifying the specific vessels to the thyroid rather than to the juxtathyroid tissue. Thank you, sir.
Anyway, again, the loop is not mandatory. Do whatever is good with you. If you have a good idea of the anatomy, that's equally important. And I always tell people, at Tata's, we were 4 surgeons who operated with loops and 4 who didn't. We didn't find any difference in the outcomes of hypocalcemia. So youngsters, please pay attention to anatomy and basic principles of good surgery. No indiscriminate use of cautery, identify small vessels, and most importantly, be patient.
Thank you, sir. Thank you so much.
Right. On behalf of the organizing committee, I would like to thank Mahamaya Singh for the beautiful moderation. I would like to thank all the speakers, Dr. Shashi, Dr. Luke, Carsten, and Professor De Cruz to really give some wonderful talks and really open this thyroid meeting in a great way. So we are at the end of the morning session. So we welcome everyone. Thank you everyone for participating in this session. So we had a consistent 100 participants all throughout the meeting, and we had a very interactive discussion as well all along the meeting. So we welcome, thank you everyone for joining the meeting in the morning, and we welcome everyone for the afternoon session, which will start at 4 p.m. We got talks from Krishna Kumar Tankapan from Amrita, Professor Randolph and Professor Freeman from Toronto, and we will have an allied panel which is led by Deepak Balasubramaniam in the evening. So this panel was requested in a very short notice, and all the panelists have agreed to participate. We are looking forward to see you everyone in the evening. Thank you everyone for participating, and thank you all the faculties, De Cruz sir, Carsten, Dr. Luke, Shashi, and Mahamaya for moderating the session. Thank you everyone. We'll see you in the evening at 4 p.m. today.
Thank you, Akshay. It was a very fruitful Sunday morning. Thank you so much. I'll see you back in the evening.